May 2020. This is Dr. Kihara who's speaking. I'm speaking on behalf of the Kenya Obstetrical and Gynecological Society and the University of Nairobi, and one of the co-conveners of this particular symposium. We would want to acknowledge the partnerships that we have had with the Kenyatta National Hospital, with the Kenya Obstetrical and Gynecological Society, the Ministry of Health, White Ribbon Alliance, the University of Nairobi, and KMET. In fact, our keynote speaker is coming from KMET. I'm hoping Dr. Kireki Omanwa will be able to join us very shortly. But in the meantime, I probably can give the house rules. Please keep your microphones off if you're not speaking. You will be allowed to post your Q&As into the box, in the question and answer, or into the chat box, which we will be addressing at the end of this symposium. And if you need to actually ask one question, we will allow that if you can keep your hand raised up at the end of this session. We have eminent speakers, and we really must applaud all the gentlemen who have joined us, particularly on this topic, which under normal circumstances is very stigmatized and unspoken of. So accolades go to both the presenters and all the gentlemen who are with us and who are partnering with all the ladies, because menstruation should be something we should freely and willingly talk about, because it has dire implications, one, in reproduction, and two, even when we're talking about pleasurable sexual activity. So we want to dissect and see what we should and should not do, what we deem normal or abnormal, but above all, to take a more holistic approach in addressing menstruation, and even looking beyond just the menstrual processes, but also addressing what we mean when we talk about menstrual health management, because that is a broader outlook to things. I want to ask if Dr. Kireki is in, if he could please just acknowledge that he is there.
Can you hear me?
Yes, welcome.
Yes,
Welcome, Dr. Kireki.
Yes,
so I'll invite you officially. Dr. Kireki is a lecturer at the University of Nairobi, Department of Obs-Gynae, and he's also the current president of the Kenya Obstetrical and Gynecological Society. So Dr. Kireki, I would welcome you to give your own introductory opening remarks, and then we can move.
Okay, thank you very much, Dr. Kihara. Thank you, the organizers, Kenyatta National Hospital, Government of Kenya, Healthy Women, Healthy World, White Ribbon Alliance, COGS, of course, and all the participants who are here today. First of all, I want to thank you for taking your time off, because you could be doing other things, and you have come to this symposium, a very, very important symposium, because as Dr. Kihara has mentioned, menstrual health, menstrual hygiene is very, very important. We know that this is a day which is commemorated over, and it's always on the 28th of May, chosen because of symbolic reasons. The first one is that the average menstrual cycle takes 5 days, that is the bleed, and then the cycle itself from one bleed to another takes about 28 days. Now, most communities do not talk about menstruation, and this is a normal cyclical physiological process. And without it, none of us could be here or would be here. But why do we stigmatize it? Why do we talk in hushed tones about it? Unfortunately, in some societies, you find ladies, when they are on their periods, they are their own, they are actually isolated. I watched a documentary, I think it was from one of these, either Ceylon or one of those countries, where these ladies actually have huts where they are isolated and kept. Those dirty days, they call them their dirty days, are over, which is not right. Right here at home, in some of our communities, when a lady is on her period, when a young lady has started her periods, she is also considered in, and this leads to very embarrassing situations. For example, when our daughters start having periods and they don't know what is happening to in their lives with these hormonal changes and so on, and sometimes they don't have anywhere to go. To other problems, going to school becomes a problem. They don't have sanitary pads, so they can't go to school. If they go to school, you know, their mates, even teachers, sometimes can be very cruel to them, and this leads to other problems as well, because they know that if they go to school during the periods, they are going to be ostracized, so they'd rather stay away. Encourages absenteeism, and they lag behind in their education, which has a knock effect later on in their lives. So menstrual hygiene management is very, very essential. It's an essential aspect of hygiene for women and adolescent girls between menarche and menopause. A life course approach is in addressing aspects that relate to the menstrual period. Additionally, there is a need to address related to infection prevention practices, nutrition and micronutrient supplementation. Menstrual hygiene and the impact this physiological process has on a girl's education, economics and career, elimination of harmful cultural practices, and need to have processes that are eco-friendly for environmental sustainability. The International Menstrual Hygiene Day is a global advocacy platform that brings together voices and actions of nonprofits, government agencies, individuals, the private sector, and the media to promote good menstrual health and hygiene for all women and girls. More specifically, Menstrual Hygiene Day, number one, breaks the silence, raises awareness, and changes negative social norms around menstrual health towards provision of dignity, empowerment, and social inclusivity. Number two, it engages the decision makers to increase political priority and catalyze action in Menstrual Hygiene Day at local, regional, and global level. That is why it is imperative that we commemorate and continue being active on this day to increase awareness, to increase visibility, and to encourage our and to let them know that this is not a problem. This is something which is physiological, and where we can come in and we should come in to reduce the stigmatization. We should and must do it with a lot of vigor. Thank you very much, Dr. Kihara, for taking the lead in organizing this meeting. And I will hand over the program to you and welcome all the participants. Thank you.
Thank you, President Kireki Omanwa. Really appreciate your opening remarks. Now, without further ado, I want us to address our keynote address. And this will be given to us none other by Dr. Monica Ogutu, who is a founding executive director of the Kisumu Medical and Education Trust, better known as KMET, an indigenous organization established in 1996, based in Kisumu with a network of over 350 health providers, expanding access to sexual reproductive health. Monica is a renowned registered nurse, midwife, and public health specialist, and an alumni of Harvard School of Government. She garnered her leadership skills at Kenyatta National Teaching and Referral Hospital, where she managed a busy maternity unit, and I was pleased to work with her very closely. She is known for her ability to promote collaboration between government officials, private and public sector, providers, and communities to work together for results. Her top priorities are advocacy, task shifting and sharing, and community engagement towards social accountability. She has been a member of various technical working groups and boards, some of which include WHO Technical Working Group for Task Shifting and Sharing in Abortion Care, the Health Task Force of Kisumu County, the FIGO PPH Technical Working Group, and a board member of IPPF, SAAF, and IPAS, amongst others. Awards and recognitions: the Margaret Sanger Award of PPFA 2004 and 2006, Africa SRHR Champion in 2013 by IPATH, for outstanding dedication and devotion to women's health and rights by COGS in 2015 as a Sexual Reproductive Health Rights Country Advocate Champion. Appointed by the Kisumu Governor in 2017 to chair the County Health Task Force, a recipient of the John B. Dunlop Award by IWHC, Abortion Service Provider Champion at an Unfinished Revolution 111 conference at Rhodes University, South Africa. Currently, she is serving in the Lake Region Economic Bloc as an eminent member of the COVID-19 Advisory Committee, Health Advisory Council, Kisumu County, and Advisory Board, Saving Lives at Birth, Duke Global Health USA. Dr. Monica, and a good friend of mine, you're most welcome, and we're actually happy that you've taken time off from your travels in Migori to actually give us the keynote address. So welcome.
Thank you, Dr. Ann, and thank you, Dr. Kireki. Nice meeting you remotely. Hope to see you soon in Migori. Thank you for this opportunity to give the keynote address. And I just want to echo that this is taking a holistic approach. Menstrual health management is more than just a sanitary pad. And I'll be sharing with you the KNH model that we have implemented in this region, in this country, which takes a more holistic approach than just looking at the sanitary pads, as people think that menstrual hygiene management is just looking at the sanitary pad. This is a special day for us because being a menstrual hygiene management day, we are also celebrating the International Day of Action for Women's Health. So this is very special, all observed on the May 28th every year, where across the world, we need to spread awareness about women's health and their rights, because as Dr. Kireki has said, without Menses, we will not be here today. And being that we are talking about this during this COVID pandemic and sitting in the LREB advisory committee, I will not forget to say that women are more likely to bear the brunt of social and economic consequences. And therefore, this day aims at raising more awareness on the issues related to women's health and well-being. And therefore, once more, thank you very much. Next slide. Yeah, so globally, we all know that approximately 52% of female population is of reproductive age, and most of these women and girls will menstruate anyway. You are not a woman if you are not menstruating, and we menstruate each month for approximately 5 days, therefore May, and averagely 28 days. And therefore, this is something that is very natural, part of reproductive cycle. And in most of parts of the world and in Kenya, it remains a taboo. And therefore, if we just look at the pad only, we'll not be able to break the stigma around it because it's rarely talked about. Next. So we're talking about menstrual hygiene for all girls. Every woman in reproductive age needs to really be aware of this menstrual hygiene management as a multidimensional and critical component of our health. Especially, we always say that it is a core component of sanitation, education, and sexual reproductive health. Studies have been conducted in low and mid-level income countries like Kenya that indicate that women and girls still face a lot of challenges. And therefore, I'm so pleased that we thought of talking about these issues on this day. And they face a lot of challenges regarding access to information, the entire package about menstruation, affordability, and appropriate sanitary products that are there for them. And some of them even lack proper waste disposal. Next. So briefly, Keynote Sisterhood for Change program that started way back in 2006, where now this menstrual hygiene has been integrated, was started to address the high teenage pregnancy and early child marriages that result into high adolescent girls dropping out of school. And this was launched by our former mayor, who was a lady in Kisumu, and we talked about it, and she was the champion that started this journey, marching on the streets and talking about the issues. And we said it's not only the girls, we'll bring everybody on board if we are to destigmatize this. So the launch was in 2006. And this was also to address the limited access to adolescent sexual reproductive health, including menstrual hygiene. So we are actually emphasizing that menstrual hygiene management, information and services should be a core component of ASRH. Next slide. So our model, this is the integrated model that we are implementing. We have these 6 components. One is the SRH, age-appropriate SRH and life skills. We produce the reusable sanitary towels, and then we have the psychosocial support for these girls. Now the teenage mental health is critical, and that is always neglected. So that is also a key component. There is economic empowerment. We are linking SRH and economic empowerment, especially for the teen moms that need these services most. Some of them are as young as 14 years old. Yesterday in Migori, I saw a 12-year-old girl in maternity unit. You wonder when she started being sexually active. We also have a child care center for these girls who are already teen moms, and they come with their babies, and we have daycares, the caretakers who are also taking care of the babies while they go to class. Then we have a safe space that is Freedom House for the abuse, the gender-based violence victims. Next slide, please. So we started the production. Remember, the launch was in 2006, and we realized a major gap was the sanitary towels. Some of them cannot even afford, and therefore they absent themselves from school. 2 or 3 days, they're not able to go to school because they have no decent sanitary towels, like the girls in towns who are using the disposable always, and they throw, or they use tampons. In the rural communities of Kenya, this pad is a luxury. Most of them don't have it, and they use any crude method during these 5 days of menstruation. Therefore, we came up with an innovative way, coming up with the local solutions, going back to our roots. We never used always, but we went to school. We never used tampons. So instead of using the rags and the torn blankets, we came up with a very innovative way of stitching the reusable sanitary towels. We have stitched at our center. We have a center for maternal health innovations, and this is one of the innovations that these girls have been stitching and distributing in the rural schools to keep the girls in school and also reduce absenteeism. And this Keynote Comfort comes in a packet of 6, and once we give 1 packet, the girl can take up to 1 year with it. All we need to do is to educate them on how to take care of the pad, and also on other issues that go with the menses, the challenges that they face. The lifespan of the pad depends on the care. So currently we are a production unit that produces these pads and distribute in the schools through a network of partners and also advocates like the first ladies of some of the counties. Next slide. So all said and done, we have to do some sensitization. Keynote has been on the front line, getting into schools to talk about these issues. And we work very closely with the youth peer providers. We have youth peer providers in these schools that we have trained, and they are able to now reach out to the other girls with other issues. So we have menstrual health management, sensitization, and distribution of the pads in the schools, but we use the pads as a vehicle for adolescent sexual reproductive health information, because during that time, we also have a talking box where girls can drop their information, their questions, their concerns. And then we also have the nurses that accompany these youth peer providers to the schools, because some of them have so many questions that they want somebody to help them answer. Those who cannot ask questions that time and they cannot drop their questions also in our talking boxes, we have a toll-free line. So it's such a holistic way of addressing issues, not only the distributing the pads, but also addressing some of the issues that they have. Like some of them have dysmenorrhea, have some infection, or they have issues with the relationships. How do we make sure that all that is taken care of? Next slide, please. So you can see those are just the girls that we have who have been receiving the pads, and they are also now trained as trainers. So they train the young ones who still don't know even how to use or dispose the pads. These pads are washable. When you walk around, you'll see them hanging like face towels, and you know, they are comfortable because at any given time, although your parents might be poor, but you know, when you start your menses, you have your clean pad in the house. You might not struggle, how am I going to school? So this has really been a revolution in the rural communities. As you can see, these are rural parts of the country. Next slide, please. So as I said, we also ensure that we reach out to the adolescents with age-appropriate information. So we go to the schools and give the information, but therefore the information alone is not adequate. We need to also see how we link the information and services. So on the top, you can see the students sitting in a circle. That is what we call study circle model or that we have put in place, and everybody is there. We are able to talk about issues with their teachers. And when you talk about these issues every now and then, it becomes destigmatized. We even have boys talking about the issues, and they are able to also ask about their issues, because boys also have their issues. So when we talk about age-appropriate information, it's everybody, all the adolescents. And therefore, after that, they are separated into groups. The girls go on their own, they have their questions, they can be able to ask, and then the nurses or the youth peer providers will respond to them. And we link them with the youth-friendly clinics that we have created in this region. We have over 22 youth-friendly clinics, a network that now we have the young providers are also trained on being youth-friendly, and below is one of our model clinics where these girls come for the services. Let's not cheat ourselves and keep on saying these girls and boys don't need the information. They are already sexually active, and they are actually asking for the information. So all we need to do is to package this together, and when we offer the SRH information and services, menstrual health management is incorporated, so it is an integrated model. Next slide, please. So for us to destigmatize, as you are aware, menstrual hygiene is still so stigmatized. So we have an integrated model where we get to the communities, and here we have everybody. We have women leaders, and we also identify women champions to stand up and talk about the issues, because when the elders talk about these issues, they own the process. It's not a health issue. It is also a community issue. So Keynote has gone to communities. We have engaged them on sexual reproductive health with a more bias on adolescent sexual reproductive health. And during this pandemic, as you are all aware, STD has been on the rise, so there is no way we can leave it out. So this is also one area that we have of late integrated into the community engagement package. So we talk about all together and we come up with community-based solutions. Next slide. So I talked about our Freedom House, which is like a gender-based violence recovery center, and also offering psychosocial support. We have counselors. We have integrated psychosocial support into the package. Remember, I'm talking about a package. I'm not looking at menstrual hygiene in isolation. And when you go to the community, it is like going to the lake to fish. You fish everything. So through the community engagement, we have been able to even rescue the young girls being sexually abused. Like the girl in the picture is only 7 years old, was the youngest that we rescued. And to the center, while we were out there to talk about menstrual health hygiene, and we were there to talk about adolescent sexual reproductive health. And when you go to the community, you get other issues. You don't leave that out because it's part of the package, and that is part of the way we can now destigmatize the issues, because you go in the community with the package. So it's a very modest center. As you can see there, I know Dr. Kihara, you have visited this modest center. We have about 4 beds. We keep girls here for just about 2 weeks maximum, while we are looking for an alternative home for them. And some of them come to us when they are already expectant, and we have realized that they miss some information earlier. So if we can reach them earlier, we'll be able to prevent a lot of the issues that we are dealing with. And therefore, menstrual health management can be an entry to the community to discuss so many other issues that we always neglect. Next slide, please. So that is the Freedom House, just one success story of this young girl who was, we rescued, was 16-year-old, actually was in the school, one of the school, our target schools. And during the menstrual hygiene study circle discussion, like one of the pictures I showed early, the teachers picked out a girl who was being abused by the stepfather and referred to us. And this girl was rescued to our center. Later, we realized she was pregnant. You can see a young girl of, she was actually 11 at the time we met her. And we had to take her to Kyoto home in Muranga. We have created networks so that we are able to offer all the services that these girls need. So at that time, at the far end is the Kyoto home, where we had to drive from Kisumu to Muranga, kept her there. Luckily, she delivered with no problem. She came back to us, and these are the girls we have taken back to school. So the entry might be using the menstrual hygiene management, but when you enter the community, you get other issues that you need. And this is one of the girls that we have now trained as an advocate, as a champion, and is able to talk about these issues boldly. What we have done is now to empower the girls themselves as advocates and give them the voices to talk about the issues and also demand for these services. Because unless we empower them, they will not be able to talk about the issues. At the far end, that is Maseno boarding school. When she was going back to school, she's now in Form 3, and she'll be doing Form 4 very soon. And this is one of the potential leaders in this country. Look at that journey that this girl has taken. It's a real success story. This is just one of the few. We are documenting a book that is titled Against All Odds. And that will tell the stories that the girls go through just with one small mistake. And this girl was impregnated by a border guy who actually took advantage of her because she needed some little pocket money to buy something. And maybe you are given just 100 shillings to buy a pad. And in the end, you end up with this pregnancy that will completely, damage or spoil your future, the dreams you had and everything. So that is one story that I always remember whenever I share our integrated model. Next slide, please. I'm almost there. So I talked about linking adolescent sexual reproductive health and economic empowerment. So we have a school that has been recently upgraded into, it's now Keynote Vocational Training Center. And this vocational training center, we target these girls who have dropped out of school due to teen pregnancy. Again, just like menstruation is stigmatized, teen pregnancy is so stigmatized. So the girl faces the wrath all through. So when they are pregnant, nobody even wants to talk to them about their future. So we have rescued these guys to the center. They just come from the village, from the community, come to the center, and they choose a class of their own choice. We take up to almost 150, 200 girls at a go, and they come with their babies. We have a daycare for them. They keep their girls, their babies there. They can go breastfeed at any given time, feed their children. We have a clinic where the kids can be seen, and by the time they are going home, they are really comfortable. When we started, we didn't have a daycare, and we realized that they were never settled because these were babies that are locked behind doors in the community, and nobody's taking care of them because they can't afford. So the picture is just showing different classes. We have, tailoring and dressmaking class, and they are very talented. They make beautiful kitenges. We have the other class is now the food and beverages, the catering. They even have their, catering outreach services. If somebody wants outreach catering services, the girls have already started their own restaurant. It's Swastik restaurant based in Kisumu. Below there is a hairdressing, beauty and hairdressing class. And at the far left is just a girl that is now taking these young girls through saving basic entrepreneurship skills is also part of this package so that they learn how to save. So when they make these parts or they are involved in the Center for Maternal Health Innovations, they are paid something and then they save, and we have linked with Postbank to ensure that this Princess account that they open is kept active. Next slide. So finally, I'll talk about nurturing care, our daycare. So those are my little sweet angels, the babies, those girls that you have just seen in the previous picture. When they have their babies, they drop here. At any given time, we have about 15 babies, and we have 4 caretakers. We feed them from the center. This center, we also make our enriched Nutri-Flour, the porridge flour. So we have our own meals here, and the girls are fed, supported to feed their babies at the center. So during break time, lunchtime, they sit with their babies. And this is another unique model where you make a vocational training center baby friendly. And this nurturing care model, we have realized this the best to stimulate the babies because these are the future leaders. So when we lock them back in the homes, because this girl is now facing her own challenges, then what is the future of this nation? So we are looking at these babies, and this nurturing care model is a talk for another day. It's a new model where you journey with the baby from conception. The 1,000 days of life are very critical in a baby's life because that is the time the brain develops. You miss it that time, you'll never reverse it. Even if you take them to the best academies that we have in this country, the brain is already damaged. It will not be as active as when you work with this baby and look at all the components: health, education, nutrition, safety, and all the other components that we are talking about. So the nurturing care model is a new concept that we all need to read and ensure that when we are managing these mothers who are also pregnant, we know that it's not only delivering a baby to survive, but a baby to thrive. My last slide is basically concluding. Next slide. So in conclusion, I just want to say that there is need to extend menstrual hygiene management solutions beyond the schools, beyond the sanitary towel. We need to have an integrated, holistic outlook to minimize so many missed opportunities that we are having when we are reaching out to these girls, or when we are talking about menstrual hygiene management. Let's think out of the box and let's have integrated, holistic outlook in the packages that we put in place to reach out to these girls, either in the community or in the school. Thank you very much, and I appreciate all of you for listening. I'll be available for any questions or any clarifications. Thank you, and back to you, Dr. Kihara.
Thank you so much, Dr. Monica. You couldn't have put it better. Well done to KMET. And thank you for giving us hope out of hopelessness. And the hopelessness starting from really very, very young adolescenthood with the starting of menarche. And secondly, the empowerment. I really felt very excited with what you presented to us. And even the comments coming in Q&A are flagging the same. So we'll move to our second presenter. And our second presenter is Jane Koetch. She's a nurse by profession, has a master's in nursing education, currently working with the Ministry of Health as a senior program officer, Division of Community Health Services. So Jane will be speaking to us on MHM, Empowering the Community Strategy. So welcome, Jane. The stage is yours.
Thank you very much, Dr. Ann Kihara, and panelists and attendees. Good afternoon. Thank you very much. As Kihara said, my name is Jane Koetch, and I work for the Ministry of Health, the Division of Community Health Services, which particularly looks at level 1 as a service delivery for the country. So maybe I'll start my presentation looking at what community strategy is. How can we use the community health strategy to leverage on menstrual health, menstrual management hygiene, basically. Thank you. Maybe you can put on my introduction. So this is my presentation outline. We will have the introduction, what community health vision, mission, and goal, the guiding principles, the community health structures. When we talk about community, what it entails, service delivery by cohort and level, using CHS to accelerate universal health coverage, and CHS strategic direction to leverage on menstrual hygiene management and addressing menstrual hygiene management at the community, and some of the ongoing activities that we are working in the context of COVID with other partners in addressing key interventions that are emerging from COVID as a country. Next. As you are aware, in 2010, the Constitution of Kenya introduced a devolved system of government that provides every Kenyan citizen the right to the highest standard of healthcare. And in Vision 2030, it also defines a community health as a key pillar in achieving the Vision 20 through increased preventive, promotive healthcare at the community level. And community health system looks at it's a people-centered approach or a humanistic, it adopts a humanistic approach. And it coins to the community health, it sees the community health service as one of the core service delivery under the Kenya Essential Package for Health. And it is in that premise that community health units or community health is key in delivering level 1 services for the country. Next. So what are the goals, the vision, and the mission for community health strategy? The vision we have is a health people living in high quality lives within a productive and vibrant communities. That is the vision for the community health strategy. And the mission is to empower people to live a health through transformative, responsive, sustainable community health activities in Kenya using the primary health care approach, or the PHC. And the goal is to improve service delivery to all Kenyans through integrated, participatory, and sustainable community health service towards universal health coverage. As a country, we are geared towards achieving universal health coverage in all 47 counties. Next. Next. So what are some of the guiding principles that is helping us to achieve this? One, we recognize health is a basic right as enshrined in the Constitution of Kenya 2010. It also adopts the integrated and collaborative service delivery approaches, including partnership, collaboration with actors outside health. We work mainly with non-state actors so that we can be able to achieve our deliverables or our goals as a country. Another one is alignment of primary health care as a driver of universal health coverage. We are adopting PHC for us to achieve universal health coverage for this country. And also the attainment of the highest standard of healthcare is aligned, and it is a right for each and every Kenyan citizen to get the highest standard of healthcare services, emanating from level 1 up to the highest level of service delivery. We're also including the communities as the partakers of service, and there is also the social accountability aspect that the communities need to request from the duty bearers as they are the uptake of services at those levels. And last one is to enhance use of innovation and appropriate technology as we serve Kenyans. Next. So when we talk about community health structure or community health structure, what it entails is at level 1 or tier 1, we have a population that is being served, an approximate of 5,000. We have also households within that population, that's about 500. And we have a workforce, which they are supposed to provide services at community health unit. And 10 volunteers serving a population of 5,000 or a household of 1,000 households. And we also have a governance structure, which is community health committees, which comprise of 5 to 7 members, drawn from that community health unit or drawn from various households within a community health unit. So if we look at our Kenyan population, we have about 47.5 million Kenyans. And if you translate that, it is coming to 12.2 million households. So in our, as a ministry, we want to reach all that population, all those households with services or community health services. And currently we have about coverage of 89% community units established across the 47 counties. And this translates to about 11% of country that is not covered by community unit. So this means that each and every county has a community unit that the community health volunteers and the community health assistants provide services at those lower levels. And in terms of the numbers of the community health volunteers, we have about 94% coverage. Means we have, in total, we have about 89,670 volunteers out of the expected 95,130. It leaves a gap of a meaning of like 6%. So entirely we have a pool of resources that provide services at the community level. We also have the community health assistant. This is basically the supervisors of our community volunteers. In the country, the coverage is 34% out of the expected of 9,513. And it shows basically we still have a long way in ensuring we have more of supervisors who will be able to provide leadership or oversight at the community health units so that the households can be reached with information, can be reached with services that they can be able to reduce the number of frequencies visiting a health facility, and they can utilize that time by engaging in other socioeconomic activities. Next. So this is the organogram or the structure of our community health units work. So in the lower section, we have the households, about 50 to 1,000 households, which is equivalent to 5,000 population. We have the 10 volunteers per community health unit. We have 1 to 2 community health assistants or community health officers. And then we have the tier 1. Then under tier 1 of the community, we have the community health committees. That is, its responsibility is more governance and oversight at that level. And each and every community health unit is linked to a primary health care, either a dispensary or a health center. And we also have the facility health committees, which they also support the work of the community health level or tier 1. And also we have after the primary health care, we have the sub-county referral hospitals or tier 4, which also they are linked to community units, and they serve, they support the communities or the household members in uptake of services. We also have the governance, the management structure, the facility health management, and also the community health management, that they work hand in hand to ensure services that are provided at the community respond up to the national, up to the county referral, up to the county referral hospital, primary referral, and back to the community. And the cycle continues. Next. So what are some of the key services delivered by the community health volunteers at level 1? They have been structured in terms of cohorts and level of care. So at level 1, we have all the services cutting across the cohort from cohort 1 up to cohort 6. And they have an agreed package that the community volunteers are providing at the household level. So if it's pregnancy and newborn, they have a category of package that they are supposed to provide. And those services that they cannot provide, they refer to the link facility. There's also the early childhood. They also have a category of services they provide. Late childhood, they also have a service category. Adults and youth, which this conference looks about is a key aspect of menstrual hygiene. They also provide messaging at the household, and then the adult and elderly. So they have an agreed package. So mainstreaming menstrual hygiene in community strategy will go a long way in targeting interventions based on the cohort for the girls and women of reproductive age. Next. So as a division of the ministry, and under the year 2019 to 2019 financial year to 2020, we managed to get some funding from the ministry, and we made some strides or milestones in terms of building blocks. Under community health financing, we were allocated in that year 4.2 million, and this was supposed to go to the coverage, ensuring 100% of community health units coverage. And we didn't manage to achieve 100%. However, we are at 89%. And this means if the units are functional in all the 47 counties, we will be able to see improved maternal child indicators and all the other indicators across the 47 counties. We also managed to recruit quite a number of community health volunteers, which was 32,000. An additional workforce, and we also recruited about 3,000 community health assistants. This actually we will have a motivated workforce for service delivery at level 1. Under leadership and governance, we have developed quite a number of policies, and we have developed policies that goes into accountability and sustainability and scalability of community health services. Currently, we also we are digitizing all our reporting tools for level 1 so that each and every community health volunteers, if it goes to each and every household for any service they are going to render, it is a real-time reporting, and that data is submitted on real time to DHIS2. And at the end of the day, we will have a timely, reliable information to monitor intervention and to determine impacts, even in cases of outbreak, and we will be able to have an interventions that will be able to help in mitigating outbreaks in the country. Under community health kits and equipment, we also procured a number of community health volunteers kits, and this basically was to be used by the community health volunteers to provide services at household, so that the services that the household need they can only be referred when it is when the community volunteers are not able to provide, and to the other levels of management. Next. So in our community health strategy plan 2020-2025, we have quite a number of strategic directions that we will take as a country, so that we can mainstream menstrual hygiene management. And under strategic 1, we're looking at strengthening management and coordination of community health governance structures at all levels of government and across partners. This is where we will be lobbying with the leadership in the ministry and in the other non-stakeholders to support us in ensuring that they lobby for resources that can go to schools for purchase of sanitary towels. At the Ministry of Gender, we also collaborate. We co-chair a task force on gender. And so this is where we will help in terms of ensuring that the supply or requisition of sanitary towels and other interventions can go to school in terms of even health messaging or programming. We also have number 2, which is building a motivated, skilled, equitable, distributed community health workforce. This is where we will also encourage the community health volunteers when they visit a household and they found their teenagers or women of reproductive age, they will create an enabling environment to discuss about menstrual hygiene and its management. And they'll be also looking at wash issues at the households. We also have number 3, which is increasing sustainability financing for community health. We have seen menstrual hygiene management is it's a multi-sectorial activity, collaboration from various stakeholders. So this is where we will be able to advocate for finances that can go to schools, that can go to communities, that can help young girls and women of reproductive age to get some support required, be it be safe spaces, be it be SRH services, be it be sanitary towels, be it be wash in school. This is where we will be working with like-minded partners to support. Number 4, we're looking at strengthening the delivery of integrated, comprehensive, and high-quality community health services. This is whereby we look at services that can be provided at households by community health volunteers, be it referral. If they find a woman of reproductive age having issues on reproductive health, they are able to refer so that this child, this woman or this girl can get services at the link facility, and they can continue following up to ensure there's the treatment outcome is successful. Number 5 is the increased availability of quality, demand, and utilization of data. This is where we will be able also to track services provided to women at the households and girls, and also other services, so that we can be able to help the country make decisions, or even at the national level, we can be able to mobilize resources that can go to the community health units or the link facilities required. Strategic 6, we're looking at to ensure availability or rational distribution of safe and high quality commodities and supplies. Currently, we are community volunteers are being given some commodities or equipment to provide to use as part of their routine service delivery at the household. So we are looking at the provision of services, and maybe in future we will also include, if the ministry or the partner look at, we can include the maybe the local sanitary towels that is locally manufactured as part of also the role of community volunteers, so that they can be able to we retain our girls in schools, and they can also be able to support the vulnerable, especially those who are in rural areas. Number 7 is create a platform for strategic partnership and accountability among stakeholders and sectors at all levels within the community. This is where we are looking at the private sector and opportunities for franchising, financial support, or any other support that they can support it going towards the service delivery at level 1, and also girls and women for reproductive. Next. So these are some of them. At the household level, we will envision that as we address issues on menstrual hygiene at the community or household level, the community health volunteers will be able to engage the community, engage women and girls during the dialogue days. When we have a dialogue days at the community health unit, they will be able to discuss issues concerning issues related to menstruation during the action days, during the monthly meetings, and also distribution of IEC materials at the household. This is very key in terms of empowering the girls and women at those households. They will also be able to normalize the period so as to create a conducive environment for girls and women to be comfortable. Sometimes in some culture, there are some communities, they are sensitive on discussing issues to do with menstruation. So if the discussion can happen at that household, it becomes part and parcel of life, and it will not be a secret, and it will not be like a stigma. So somebody can approach anybody, or a girl can approach anybody and discuss menstruation. So because it is something that it has been discussed over and over again. So it is no longer a stigmatization, but it is a normal. It's something which has been normalized. Another thing is building the capacities of community health workforce to address menstrual health issues at household. If there's an issue, the community health volunteers can deal with in the household relating to the menstrual hygiene. They can be able to discuss and they can be able to refer. They also need to mainstreaming menstrual hygiene awareness with the community members, households, or parents, teens, or boys. This is important so that they can be able to help the girl and help the woman during the menstrual cycle. We have a covenant structure known as community health committees. We use them to be the champions for the menstrual hygiene management at that level, so that they can be able to talk freely and support girls. And we were conducting a COVID-19 survey, and we were interviewing some household members last week, and I got a parent who was a single parent, and he was telling me that he's supporting the girls he's bringing up to buy sanitary towels. And as a father, it was not comfortable, but he was taking that role for the mother, and he could say, "I'm buying everything every man I have to buy." So it was that parent was empowered, so that he can even talk in a forum like that to say, "I'm the one buying sanitary towels for my girls, and I don't feel any discomfort." And last and not the least is to advocate households to have a functional wash facilities. In most regions, we are looking at functionality of wash facilities, be it a toilet, be it a latrine that can be used for disposing of the towels, those which are disposable, and those which are reusable, they can be able to get water and wash it. And finally, to encourage private sector and public-private partnerships so that they can be able to manufacture low-cost sanitary towels, or even donations that can go a long way in empowering the girl and retaining the girl in school. Thank you. Next. I just want to bring this slide, some of the activities we are doing as a division. So currently we are developing a community scorecard guideline. This is basically accountability tool that will be able to hold accountable. The community members will hold duty bearers accountable of the services that they are providing. So if we have this guideline in place, even the issues concerning sanitary towels, challenges in access of wash facilities, this will come in, and it will help the duty bearers to be accountable or to provide sanitation services in those rural communities. We're also developing accreditation and certification guidelines. This will go a long way in ensuring the volunteers that are working at the community level are able to be certified, and we are also looking for accreditation body that will be able to accredit community health assistants so that they can be able to provide services at level 1. And this is supported by AMREV and KNH-UON, and these activities are ongoing. We are happy to report that also we have managed to get some funding from the TOK under universal health coverage, and we managed to hire 1,750 community health assistants across the 47 counties. So part of what I presented about the charts, this number is part of what was recruited in the financial year. We are training also community health assistants at the KMTC, and a scholarship by the government, and we've managed to train 230. Okay, thank you, Chair. We have managed to train about 230 and 160, and we're happy to report to you that all the CHARs graduated from the KMTC this year, and they are going to be deployed at level 1 to provide services. We are also a task force at the National COFAS Task Force Vaccine Initiative, where we are looking at mobilization of resources and also risky communication for the uptake of vaccine that has been enrolled. We are also engaged in the community engagement activities under COVID-19 emergency project under World Bank. And there are quite a number of activities we are supporting under that project that is cutting across 8 thematic areas. And we are rolling it out in all the 47 counties. And our division has been charged with some of the activities that we are implementing. Under that is a GBV project. We are also supporting the division. We are also in partnership with the POP Council, the Population Council, and we have so far conducted 5 CAP surveys, and 1 survey was on impact on COVID-19 on community health volunteers. And there's a lot of rich of information on that CAP survey. And I think we are going to publish some of the 4th survey that we have conducted has been published, but it's in our website. The last one we conducted on the month of May, and it will be published also for people to go through them and also see areas that they can give synergy. We also have the community health service bills that are ongoing. Some are in parliament, some have been ratified by the county government. And lastly, we have managed to digitize all the community health service information system. So we are moving away from the paper-based to our electronic reporting system. Next. Thank you very much. That is the end of my presentation, and thank you for listening. Back to the chair.
Thank you very much. So I'll ask Dr. Kireki to take over from me.
Okay. Thank you very much, Jane, for that, that presentation, the activities that you're doing, community health assistance and so on. Very, very important aspect at the community level. The next topic that we're going to have is life course approach to menstrual health management. And the presenter is Dr. Anne Beatrice Kihara, famously known as Dr. ABC. Dr. Anne Beatrice Kihara is a friend of mine. She's a good friend of mine. We have worked together. When she was a chairman, the president of COGS, we worked together. I was in the council. She is a senior lecturer at the University of Nairobi, Department of Obstetrics and Gynecology, an avid researcher, written very many research publications. She did her MBCHB and MEd from University of Nairobi, quite well traveled, did global health research from University of Manitoba in Winnipeg in Canada. And presently, she's the president of Africa Arab Federation of Obstetricians and Gynecologists. And just to let the cat out of the bag, hopefully, please cross your fingers for her. She'll be the next FIGO president. So let's pray for her and let her, because I think she'll make a fabulous president. So Dr. Kihara, the floor is yours on the life course approach to menstrual health management. Thank you.
Thank you, Dr. Kireki. I've just put that slide at the introduction. I want us to all know that we do have the menstrual ring chain, and this is really what's going around the globe, that all of us should be speaking about menstruation. Next slide, please. So that's my brief outline. I'll give a background, give a few definitions. The effects of menstruation on school-going girls, the life course approach, and what we should be considering when we think menstruation. Next, please. Bit crowded, but important. Menstrual health is a broader terminology than menstrual hygiene. It encompasses both the hygiene elements and the broader systemic factors that link menstruation with health, well-being, gender, education, equity, empowerment, and human rights. Example, the rights to wash. Information, access, use, and disposal management. Menstrual health management. Women and adolescents use a clean material to absorb or collect menstrual blood, and this material can be changed in privacy as often as necessary for the duration of the menses. It also includes using soap and water. Thank God COVID came, an opportunity arose where more centers and more places have access to clean water and soap. And the washing of the body as required, and having access to facilities to dispose of used menstrual management materials. We, however, need to focus on our own indigenous knowledge system or culture associated with menstruation, because in a lot of homes and in a lot of our cultures and ethnic backgrounds, it is deemed once you begin your menses, then you are fertile and motherhood ought to start. Unfortunately, it's also a time of misinformation or lack of information, of fear, embarrassment, shame, and taboos. And we need to reflect on the economic cost to the nation and development when you have a young menstruating girl who soon gets into motherhood, and a vicious cycle of poverty that emanates not just for that index girl, but even for the babies that she's carrying. Next, please. So there are about 3.73 billion women in the world. WHO says 52% are in their reproductive age and therefore menstruating, and giving us a figure of 300 million girls menstruating daily. Mind-boggling. 663 million people lack basic access to safe water, and 2.4 billion people lack adequate access to basic sanitary conditions. For women and girls, the lack of safe, accessible water and sanitation, WHO, particularly at the time of menstruation, say that they have a far-reaching physical, hygiene, and psychosocial effect. So I cannot echo more what Dr. Monica talked about. The psychology with menstruation goes far-reaching. Menstrual hygiene management issues have been ignored, unfortunately, by professionals. A holistic approach that addresses not just the hygiene, but the education, the nutrition, the sexual reproductive health needs, the mental health, the culture, and social livelihoods is therefore required. Next, please. The onset of menstruation is challenging for school-aged girls in low-income countries, and especially those who are vulnerable. And I will mention a few. 1, the rural populace. 2, urban informal. 3, COVID-19 came to disrupt us. And what has happened? Even when you have nurses and doctors in PPE, we hardly remember that PPE can be a nightmare when it's compounded with a menstruation that is going on. So we need to really get out of our comfort zones and really think holistically about the gender and the woman who's menstruating. Impacts can include school absenteeism, missed classes, reduced participation, teasing and bullying, fear and shame, and risky adaptive behaviors. We've had so many stories that speak about menses and boda and sex for pads. This is ongoing in this country. It's further challenged that menstruating schoolgirls face a lack of knowledge and communication. The girls are at risk of reproductive tract infections because of poor menstrual hygiene management, and reproductive tract infections can therefore lead in the long haul to infections that extend even into their pregnancies. Next, or infertility. So this is, next please. So this is my idea. We have a precious red drop, but we need to better understand with a life course approach. Next, please. So let's start with what's normal. Normally, the cycle is 21 to 35 days. Amount is 80 to 100 mLs. Duration is 2 to 8 days. The pattern is commonly regular and consistent, but not in clots. Associated symptoms that can happen with menstruation include breast tenderness, food cravings, some pain or a dragging pressure effect in the lower abdomen, commonly mood swings, and premenstrual syndrome. Next, please. So with the life course, we'll start right from birth. When a little girl comes out and is born, there is a spillover of the maternal hormones into the baby. So there are two systems. There is the breast, so the baby may look like it has a breast because of the hormonal effect, but she may also have a pervaginal discharge, which could be whitish or bloody. In childhood, it's commonly very quiet. So before you get into menarche, but what are some of the things that can make a girl dribble some blood in that system? Commonest is foreign bodies. They're playing and they put in a little bean or they put in a little bead, get some irritation, some bleeding drops out. Some cervicitis or vaginitis associated with infections, trauma, sexual violation, and we do have a vaginal tumor that we call sarcoma butyrioides, which I've drawn there, which again can give you some bleeding. Next, please. At puberty, we expect this. It's part of the secondary sexual characteristics. So you have a growth spurt, you have breast development, you begin to develop pubic hair and axillary hair. But the hallmark for every girl that she has attained sexual maturation is menarche, which means the beginning or heralding of menstruation. We may have congenital abnormalities that are in the uterus, so you begin to see abnormal patterns. Then we have pregnancy and childbirth, but I must put a rider here. The bleeding associated with pregnancy, we don't actually call it menstruation because there is other products that do come out with that blood. But for purposes of lay people, then they say there's some bleeding that's coming through my reproductive tract. And this can happen in what conditions? Ectopic pregnancies, H-mole or gestational disease, miscarriage or an abortion, some infection, cervicitis or vaginitis, infection with human papilloma virus, or with fibroids in pregnancy. Next, please. Late pregnancy bleeding. You have a low-lying placenta. You may have abruption, which is disconnection of the placenta from its normal implantation site. You may have rupture of a uterus, or the bleeding that happens in every woman post-delivery, we commonly address as lochia loss. Then instrumentation and douching, trauma and rape, and other infections like candidiasis, trichomoniasis, human papilloma virus, or genital ulcers. Next, please. So life course approach, you cannot run away from some family planning methods that can give you some abnormal menstrual type pattern. Commonly, we see this with progesterone-based drugs. We can see it with even the intrauterine device. But you have also gynecological issues, and I will not belabor so much here because this will be covered by my colleague. But just mention a few: fibroids, abnormalities with blood clotting system. You need to really know what's going on. Abnormalities with the ovaries, so you have hormones that are produced abnormally. Infections again, or you can even have it in your postmenopausal years when you have women who undergo hormonal replacement therapy, just to mention a few. I have put menopause there because a lot of people say, when should I stop getting my menses? On average, it's about 50 to 55 years. But you may find some ladies may extend. Be wary. It may not be menstruation, but reproductive tract pathology. Next, please. So what should we really think about when we're talking menstruation? Some of it has been alluded to us, but age-appropriate comprehensive sexual education in school and out of school. And what IEC materials are we actually providing them? We need to rethink our indigenous cultural system with value proposition, not starting motherhood at age 9, motherhood age 10. What happens to that girl? The tools for screening, diagnosis, and management, both in the community and facility run, we need to begin to really challenge what we have accessible to us. Reducing the 3 delay for quality of care, being prepared in the first place, being able to recognize and respond and review, and then look at reproductive fertility regulation versus infertility. Very key area that we need to begin to think about. Next, please. Menstrual hygiene management. A lot of us are now cognizant of the sanitary wear that we have, but what are the issues? Am I able to access? What is the cost? Is it available? Is it acceptable? When we talk about the Ruby Act, how many people really can access it, and can we actually use it, and can we be able to wash it? Water and sanitation, I cannot belabor to this. Then attention, particularly to whom we call primary actors, the vulnerable and marginalized, persons with disabilities, persons with reproductive cancers, persons in humanitarian crisis. Prevention strategies, nutrition is key. Every menstrual drop, you're not just losing blood, you're losing iron, you're losing folic acid, you're losing protein molecules. So the macro and micronutrition. Well, woman-centered clinics. Most of us come to hospital with pathologies when we are sick, but where are the health promotion and preventive clinics? Not just at clinic level, but even within communities. Where is the self-care, where girls feel that they have the health literacy to actually understand what's happening in their bodies? Immunization access and coverage for HPV as an integrated program, particularly for these youngsters, when we're saying we should be able to give them these injections at a very early age. PMTCT practices and zero rating of blood-borne infections and transmission. Mental health, what's the girl's self-esteem, body image? What are the school programs telling them? What are the caregivers doing for them and advising them? Next, please. Legislature and policies. I thank God we have a nation that is sensitive, but sometimes you wonder, yes, we have the programs for menstrual products and the relief from VAT and the fact that we're increasingly moving to eco-friendly products. But when you have school closures for protracted durations, and it's in the school programs, these girls are accessing their sanitation. Are you then surprised that we got a lot more teenage pregnancies and gender-based violence last year or during the holiday breaks? Let's think about this and move out of the box. Capacities of various sectors to address normal and abnormal bleeding, gender empowerment, education, changing social determinants for girls. I must applaud KNH. That is what you're really doing, is changing the social determinants, that they shouldn't suffer from abject poverty. Resources and having a rights-based approach. But above all, how many of us are conducting implementation research to actually see what are the girls really saying? And I'm thankful that we have White Ribbon Alliance who will come and tell us what's really going on ground zero. Next, please. Health and hygiene. I've mentioned bloodborne diseases, hepatitis, HIV, protective clothing, sanitary kits. So you're moving beyond the pad. You may also need the underwear that goes with it. Engagement of male as empathetic hygiene and sexual relationship partners with us. Community engagement and taking action for community-led total sanitation. It's unfortunate, 21st century, we still have open defecation or taboos that prevent even women accessing the actual latrine. They're told, no, 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 go around the back. Enhance community strategy, so information, hotlines, and social media, and promotion of partnerships and linkages that address menstrual health and integration with other services. Next, please. So the short and long is this. Much as you're taking a life course approach, you must also think of the continuum of care and constantly evaluate within your caucus, whether you're working in Nairobi or working in Migori or working in Northeastern, what is the context for my girl who's menstruating in my county, and how can we all make a difference so that she has a smile? Thank you very much. Kireki, back to you.
Thank you, Dr. Kihara, for that presentation. I can see we are really trying to keep time, which is a very, very good sign. Our next speaker is Dr. Susan Adongo Meme. Susan Adongo Meme is actually very well known amongst our circles as a writer. She writes every so often. We wish Susan would write a lot more often about medroom eyes. Fantastic stories there with a learning points at the end. Susan Adongo is a consultant, obstetrician and gynecologist, and she has a special interest in adolescent health. And she's currently working as a consultant in Kenyatta National Hospital Reproductive Health Department. And she will be presenting on MHM and nutrition amongst the youth. Susan, thank you.
Thank you very much, Dr. Kireki, for that introduction. Thank you very much to the panelists and the participants. Today I'm going to talk about menstrual health and nutrition amongst the youth. Next. So we'll go through an outline. I'll go through the introduction. Why is it important for us to discuss this? A few of the nutrition problems of adolescents, and then we'll tie it in with the challenges of menstruation and nutrition. We'll talk a little bit about the hidden hunger and give guidelines for a balanced diet. Next slide, please. So the food you eat and your menstrual cycle have a complementary relationship. We've just had Dr. Kihara tell us about how every single month, anytime an adolescent girl has her menses, or actually any woman of reproductive age has their menses, there are nutrients that we lose throughout the month, okay? Because we know that for those 2 to 7 days, when you're losing approximately the 20 to 60 or about 80 to 100 mLs of blood from your body, it also comes out with certain macronutrients and micronutrients. So that is why we want to discuss this topic, because nutrition is a vital component for the adolescent girl. Next slide. So why? The average age of menarche has reduced over time. And researchers possibly think that this could be due to the change in our diet. When we invest in adolescent nutrition, we have economic and social benefits. So we invest in the nutrition of the adolescent, they become more productive, they have increased intellectual capacity, and in the long run, we have saved on their healthcare costs. We want to address the challenges of nutrition because they have issues of undernutrition, in issues of anorexia nervosa, in chronic illnesses. We have issues of overnutrition, which is associated with obesity and its complication. We have specific deficiencies that they suffer from. We have binge eating and eating of junk food. So all these things all tie together and actually can affect the menstrual cycle of the adolescent girl. Next slide. So on undernutrition or anorexia, this can occur in issues of famine, in issues of starving oneself, or what we call fasting, or in acute fasting diets, you can see from the diagrams. And this undernutrition or anorexia or bulimia being purge eating, how this affects the menstrual cycle, they can cause amenorrhea or anovulatory cycles. Why? Because they cause hypothalamic dysfunction. And we know that the gonadotropin releasing hormone is released from the hypothalamus. So it causes GnRH dysregulation, and this in fact also affects the menstrual cycle, causing maybe primary amenorrhea, which basically means delayed onset of menarche. Next slide, please. So still on continuation of the undernutrition, we know that we need a minimum ratio of fat to lean mass to achieve menarche. Menarche being the hallmark of, or the onset of menstruation, about 17% of the fat. So when you have the undernutrition, you're unable to achieve this lean mass, leading to amenorrhea, and even to maintain menstruation and to maintain female reproductive ability, you need approximately 22% of the fat of your body weight. So basically the second bullet just says the same thing, that undernutrition and weight loss in the range of 10 to 15% of the normal weight for height delays menarche and causes amenorrhea, affecting the bone and muscle mass. Of course, it also affects your metabolism, your core temperature, and your fat storage. Next slide, please. So a little bit on obesity. What is obesity? Obesity is essentially taking in more calories than one uses, more or less like overeating. So you can have maybe oversized food portions or lack of access to healthy foods. Sometimes it could be just lack of physical activity when you have, teenagers sitting in the house playing video games, or it could be a genetic or family history, or because of hormonal imbalance. And some of the signs and symptoms are, as we can see in the diagram, where the scale shows you have gained weight, you have extra fat in the midsection, and you will see some patients complaining of difficulty in doing daily activities or being lethargic. Let's see the next slide to see how obesity now affects the menstrual disorders associated with obesity. So obese women often present with abnormalities in the amount of the menstrual flow. There's an issue with the regularity, an issue with the duration. I'll not go so much into it because my senior colleague is going to talk about abnormal uterine bleeding, but some of the complaints of obesity associated, some of the menstrual disorders associated with obesity are things like oligomenorrhea or menorrhagia or amenorrhea or irregular menses. And actually it's because of the effect on obesity on the hormones, on the sex hormones. So you have increased levels of estrogen due to peripheral conversion of androgen to estrogen. Then you have increased insulin with insulin resistance and increased testosterone. Okay, this then leads to chronic anovulation, endometrial exposure to unopposed estrogen, and then hyperplasia, and eventually heavy menstrual bleeding. So you're seeing how our nutrition, whether undernutrition or overnutrition or malnutrition, eventually affects the menstrual cycle. Okay, next slide, please. So a bit about the hidden hunger. So there are various approaches we can use to address the micronutrient deficiencies that come about because of menstruation. So we can go with the food-based approach, which basically involves dietary diversification, where we'll talk about, which you'll see in the next slides, I'll talk about the rainbow diet and the 8 guidelines of a balanced diet, whereby you incorporate high micronutrient density to your staple diet. Another way we can address micronutrient deficiencies is by food fortification, which we do where you can fortify maybe the flour. Like, you know, during the menstrual cycle, you lose a lot of vitamin B complexes, the folate, the iron is lost, vitamin C, we have the electrolytes, we lose potassium, we lose calcium. So all these things can be used to fortify the flour, the milk that we take, and it's fortifying the basic foods that most people can be able to access, okay? Another approach we can use is supplementation, which we know about. Supplementation in terms of the tablets and the capsules that we give. We have over-the-counter multivitamins, some of them 1 a day, that people can take to replenish the micronutrients that we are losing. And another way is public health measures, okay? Like now this symposium that we're having, we give health education through the community, the adolescents, just making them aware of what is occurring in their bodies, so that they can have that behavioral change, and also improving sanitation and hygiene. Next slide, please. So this is just a brief overview. I just thought I should do a brief overview just to, just show us some of the naturally occurring things in the community that we can do and that we can advise our adolescents to do and take, just to be able to replenish the nutrients that we're losing. For example, green and leafy vegetables, the spinach, the kale that you have, they have high amount of nutrients like potassium, calcium, iron, and vitamin B, which are essential during menstruation. Remember, when you're losing all these things, you end up with fatigue, some end up with dizziness, nervousness. So you find an adolescent who's always tired, they're not productive, they're complaining of headaches. So these are some of the things we can ask them to take. They're also rich in fiber, which is important that to help prevent bloating. Bloating is very prevalent during the menses and even in the premenstrual phase as well. Next slide. Other things you can take are nuts. Nuts, these are like walnuts, pumpkin seeds, soybeans, almond nuts. These are very essential. They are rich in omega-3 fatty acids. Omega-3 helps to reduce inflammation, and this is important because they help in decreasing menstrual cramps, or what we call dysmenorrhea, which we know is one of the more disturbing thing that affects the young girls. Yeah, this omega-3 also helps in reducing serum testosterone. In my previous slide, I've talked about how obesity increases the levels of testosterone in the body, hence causing irregular menstrual cycles. So this can also, it has been postulated that they can also assist in regulating the menstrual cycle. Next slide. So fresh fruits, I cannot overemphasize to all of us the importance of taking fruits, taking the water-rich fruits, which increases the hydration. And I think Dr. Kihara spoke about this. When around ovulation, there's usually a sugar craving. And most of the times you'll find someone binge eating on sweets, cake, basically processed or refined sugars, causing sugar spikes that are not essentially healthy. So this is when you encourage them to take sweet fruits, okay? The apples, the pineapples, the grapes, they help curb these sugar cravings and they're healthy as well. These fruits also have manganese, which in combination with calcium is actually good for the pain and mood related symptoms before and during menstruation. So it helps with the pain, the dysmenorrhea, and the mood related symptoms. So generally fruits in general are good. Next slide. So the whole grains, which we know about, the beans, the lentils, the peas, they also provide the body with fiber and protein, which is essential for improving hormonal imbalance. To improve the hormonal imbalance, you're able to regularize the menses. In addition, we have the vitamin B, which also is postulated to help in preventing heavy menstruation. Next slide, please. And also, I cannot overemphasize the importance of water for each and every one of us, of course. It has a modifying role in reducing the menstrual bleeding duration and even the painkiller utilization. Okay, water also helps reduce the symptoms of bloating, and it is readily available. And it is actually recommended that during the menses, one should take about 9 to 10 glasses of water a day. Next slide, please. So I think I'd mentioned a little bit about this before, but these are just naturally occurring nutrients, naturally occurring remedies for dysmenorrhea, other than using analgesics, which not everybody may have access to. You can take your chamomile tea. Chamomile tea has glycine, which acts as a nerve relaxant. You can take cinnamon, which we have. Cinnamon helps also improve the nausea and vomiting that is associated with menstruation. We can take ginger. You grate a small piece of ginger into hot water. It helps with pain relief. Some studies even say it is as effective as ibuprofen in management of dysmenorrhea. And you can also take dill and fennel seeds that you just boil in water and drink. These are all useful in pain relief. Next slide, please. So I'd mentioned, I'll talk about the 8 guidelines for a balanced diet. It's simple to remember. It's important for each and every one of us, not necessarily just for menstruating women. Base your meals on starchy foods, preferably vegetable starch. Eat lots of fruit and vegetables. Eat more fish. Cut down on saturated fat and sugar to also help with weight control. Eat less salt. Be active. Drink plenty of water, and don't skip breakfast. These are easy to remember, easy for us to communicate to our young menstruating girls. Next slide. And I'd spoken about the rainbow diet. Of course, it's shaped like a rainbow, so it's very easy to remember. Basically, it's an health-inspired trend that promotes colorful whole foods. So it's foods that are recommended are healthy fruits and vegetables, and you follow the colors of the rainbow. The Richard of York gave battle in vain, the 7 colors of the rainbow, to enhance your diet and to remind yourself that we need these kinds of healthy items to replace the nutrients that we're losing every month. Next slide. So in conclusion, this is a young girl, being able to lift a weight. So empowering women, we are now empowering women and girls through good menstrual hygiene and through healthy nutrition, healthy food choices. And yeah, thank you very much. Those are my references. Thank you.
Hello, thanks a lot, Susan, for reminding us about the different foods that we need to eat, especially the younger people need to eat. But I think even who are a little bit older can do with those nutrients, as it were. And thank you for that. The next speaker is none other than Professor Omondi Ogutu, famously known as Professor OO. Professor OO is chairman of the Department of Obstetrics and Gynecology of the University of Nairobi. Did his MB, CHB, MMed, postgraduate diploma in reproductive medicine, and presently is pursuing a PhD in obstetrics and gynecology. Interesting topic, which is his pet topic, and that is recurrent pregnancy loss, and looking at the role of natural killers. A topic I think has never been looked at in this part of the world, whereas in America, they have done quite a lot of immunological studies. He's, as I mentioned, he's a chairman of the department. He's an associate professor at the University of Nairobi. He's a member of Global Committee on Global Health. Has been a past president and secretary general of Kenyan Obstetrical and Gynecological Society. And I also have to mention that he's my chairman, and Dr. Kihara, senior lecturer, Dr. Kihara. So Professor Omondi Ogutu today will present on abnormal uterine bleeding. Daktari, what is my problem? And this is a question as the medical profession, we actually encountered this question very many times, more so when it touches on our daughters who are in the adolescent periods, when they're just starting their periods, their cycles, they find they have heavy bleeding and this consternation, they don't know what to do. So Omondi Ogutu will enlighten us on that. Yes, Professor, the floor is yours. Thank you.
Thank you, Dr. Kireki, for that kind introduction. Colleagues, ladies and gentlemen, welcome to this presentation. I will try and cut across as much as we can and cover some of the common issues people raise about menstrual bleeding, especially what we consider to be normal and abnormal, and now where are we? Now, today, 20th day, which is of May, which is a Menstrual Hygiene Day, for some interesting observation, since morning, I just decided to be posing this question to colleagues and some of the patients and the ladies I encounter. Now, from 8 a.m. to date, I think I've posed this question to about 40 women, and it's only one lady who gave me an answer just about 10 minutes ago, who told me, yes, I know today is World Menstrual Hygiene Day. I asked her, how do you know? She told me, no, I'm a BBC reporter, so I'm a journalist, I know. You can imagine, but all the healthcare workers, nobody knows. Next. This is basically the outline I will be able to go through. Next, for the sake of time. Okay, my declaration, I've got no conflict of interest, just to try and give out information to the community and colleagues so that we can improve our care. Next. Well, this is what we'd want to see, and you see this in the adverts every day, ladies showing how happy they are. Next. Okay, some of the definitions have been mentioned here and there, but remember, every young lady or any woman should know that this is a cyclic event, and it is only blood which is expelled through the vaginal birth canal, but it's also composed of cellular materials, and it is from the inner lining of the uterus, and it is actually passed through the vagina. In some very few occasions, you get abnormality whereby somebody who has had a surgery, and if the uterus is not properly repaired, you may have menstrual flow passing out through the incision site. I've come across this once, so we better know it can occur. Hormonal related, we know the two hormones responsible. Okay, and sometimes you would express it as the expression of a non-pregnant uterus, showing that it is frustrated, therefore it cries blood. Next. The duration, as mentioned earlier, between 21 to 35 days. The average is a 28. That's why you have this figure of 28. Okay. What are some of the significance? It's good to know this so that when you come to some of the abnormalities, you can be able to understand. It shows that it's a natural event. Changes occur both in the uterus, the ovary, the fallopian tube, the endometrial lining, the cervix, the vulva, and in the vagina. All these, there's a change which occurs all through. It culminates in the production of the ovum, and this therefore prepares the uterus for the process of implantation in the endometrium. Okay. Next, and it's a reflection of a woman who is in her fertility period. Although we know towards the end is non-ovulatory, and at the beginning also non-ovulatory. What, other than the first element of the significance, what is the second significance? It interferes with your normal activities. Some women have got very severe pains, as will come through. The emotional and social implications, the effect of sexual relationship. It's a trigger to show that a woman is ready for sexuality, sexual activities, the issues of fertility. And in some women in the late perimenopausal or postmenopausal, it can be a reflection to a malignant change. And in some people, if it's so heavy, you get anemia. Next. So these are some of the main areas of disorders: the abnormal bleeding, amenorrhea, and dysmenorrhea. Dysmenorrhea simply means that you have got painful menses. Abnormal uterine bleeding has got a whole spectrum of everything, virtually gynecological aspects, the palm coin kind of classification. And any woman presenting with any of these, if she asks you, is there a problem? The answer is yes, there is a problem. Okay, next. So what is an abnormal cycle? If you've got a bleeding more than 20 cycles in an individual length of over 1 year, within a period of 1 year, then you find that that is too much. Because why would you have 20 cycles in a year? Because women should be having cycles of at least, even if it's very short, 13 or 14. Then of 20 cycles, it means there's definitely something very wrong, and then it's considered to be heavy menstrual bleed, Menstruation. It means that the menses are almost moving from one to the other. When you don't have a bleed over a period of 90 days in somebody who is not pregnant, in somebody who has not been given medication or any intervention which directly affect the menstrual pattern, then you'll call that amenorrhea because you may not be very sure exactly where we are having. And when we are talking of heavy and prolonged menstrual bleed, and this is excessive blood loss, which of course interferes with what I put above their physical, emotional, and social well-being. So when you have this, is there a problem? Yes, there's a problem because it is affecting this lady's normal daily routine, her emotional status, and she feels distraught. And sometimes no wonder you say that some ladies have a lot of problems during this period of time. Some of them become hysterical. In the Greek mythology, hysteria is assumed that the menses which you see has already migrated to the lady's brain, and therefore they become hysterical. That's why we say men never become hysterical. It's only a diagnosis for women. Next, that's with a light touch, sorry. Next. This is just the figure classification of the abnormal. I'll skip this, what I was talking of a palm coin, just for you to be able to know that 40 to 60% of most of the heavy menstrual bleed may not have a problem associated with it. So they are usually just more of a primary event which comes as a result of the menstrual pattern. Next. So I've talked of what is normal menses. This is what it is. I just add that it is shortened with age, and in the younger age group, the interval may be prolonged. So when the younger ladies start getting their menses at age 11, 12, 13, sometimes the menses may be prolonged, or they might be have a prolonged interval because majority of them are usually anovulatory. Then when the same will happen towards the end, when you are getting towards the end of your climacteric period. Okay. So we say that periods can be long or short. They can be painful or pain-free, heavy or light in nature. But now, whatever you have been accustomed to as your normal menstrual period, for which you are usually, you know that when I start it will be so many days, I'll use a part for the last 3 days, first 3 days, I'll use so many. So anything going out of this your normal routine, then it becomes abnormal. Abnormal does not necessarily mean that the menses are heavy or the menses are painful. If you're used to pain and then all of a sudden now your menses are pain-free, you are used to menses of 7 days, all of a sudden they have changed and now they are going to 2 days. For you, they are now become abnormal. So I would like you to appreciate that abnormality does not mean that there's serious symptoms, but when there's a reduction of the symptomatology you're used to earlier on, the menses become abnormal in that context of definition. Next. So these are just the normal features, what I was talking about: duration, quality of the menstruum, the amount and flow pattern. And so continue. Okay, I'll quickly run through this. The quality normally can be light, bright red, or brown in color. That's normal. Should not have any smell and having little clots is normal, but technically what you get in menstruation are actually not clots, but it's just aggregation of the blood products. It does not necessarily fit the definition of clots the way we know it in hematology. Next. So some of these investigations usually are done just to look at what you'll be able to get in. I'll skip this. Next. Okay. Now, I just wanted, before I go to the next series of slides, just quickly give you a different definition of something here. What is menstrual cycle and what is menstruation? The cycle is a description of the changes you see during the menstrual period. That is the follicular phase, the ovulation, and then you get the luteal phase. That is the menstrual cycle, okay? Now, when you talk of the problem, when you talk of menstruation, you're now talking of one of the four phases of menstruation, the time when there's the flow. But the cycle is the whole sequence of events. So let's not mix the two, cycle and menstruation per se, they mean two different things. So you can have a problem in the menstrual cycle, or your cycle may be okay, but at the time of flow is when you have a problem. Next. We've talked about the volume, continue. Average is 35 mLs. The flow pattern, if you remember in cardiology classes, the so-called crescendo, decrescendo, mama, that is what the flow pattern of menses should be. Starts light, increases in amount, then drops. That's the way you remember the crescendo, decrescendo pattern of the mama, the heart mama we used to get when we were doing cardiology in medicine, in internal med. Next. So these ones have been mentioned. I think Dr. Triple A mentioned, that is Susan. I call her Triple A, she knows why. Now, these are some of the common symptoms, the breast changes. Sometimes it can be so painful until the lady says something is abnormal. Abdominal irritability, fluid retention, they gain some slight weight gain during that period. Cramping is the mainstay. And some patients present with diarrhea, vomiting, dehydration. This one usually you get in the younger age groups. And some of these patients, there are some, you find that they have got occasionally typical polycystic ovarian problems. These are the ones who present with this kind of symptom and may require admission and rehydration. Constipation, mood swings, those ones go without saying. Next. I've talked about this is just a pictorial representation of the faces. Continue. This is to show you the hormonal involvement of the menstrual cycle. That's why it can easily go haywire. You have the FSH, LH contribution, the effect of prolactin, and then so it shows you the role of the brain, the ovaries, the uterus. Next. Now, in this slide, I just wanted to mention something interesting. It is very difficult for people to quantify. When you ask somebody, especially the younger ladies, tell me, how much are you losing? My periods are very heavy. So this was a study which was done amongst the adolescents to try and show pictorially how much they lose. And it was found that only 14% of the young ladies were actually able to correctly predict the amount of blood they lose. Majority, about 65%, could not be able to pick up the correct. And a big number, overestimated by 65%, and 7% of the ladies were able to overestimate that they are losing up to 1 liter, when in actual fact, what they were losing was almost about 30 minutes, because the amount of blood they see, they just imagine it's a whole tank. A whole bucket they are losing, and made them become very scared. Next. Okay, this still the same, and this looking at the menstrual knowledge. This is just to show some of the studies which have been done to try and look at what are some of the overestimation women have, and this is one of the things which brings lots of problems. I've just indicated the figures here, and therefore they makes them start imagining that something is wrong with me. My menses are abnormal. What do I do? And they run to the doctors for advice, only to be told that it is not as bad as it is. Next. Okay, just now to come down to what then does the menstrual cycle actually portray? It acts as a mirror to the lady's health. Why? Because if anything goes amiss, it shows that there's something, either your hormones, there's a problem with it. Is there a uterine abnormality? Is there an endometrial abnormality? What is it? Because it can easily give you symptoms of anemia and all that, okay? So therefore, you need to understand your menstrual cycle, track it so that you pick up the normal and the abnormal. And when you notice you have an irregularity, please go and ask for advice. Next. Still representation again of the menstrual cycle. What is it in ovulation? Look at the various thickening you get during this period of time. Next. This still another representing the various ways so that you can be able to depict what exactly happens in the menstrual cycle. The other one just showing the lining. Now this shows you exactly what happens in the tube, the ovary, the uterine lining. Next. This now more of a pictorial representation of the changes, thickening of the endometrial lining, and also what happens in the hormonal involvement. Okay, follicular, pituitary involvement, and the cycle as depicted by the endometrial lining. Next, please. Okay, I'd mentioned this earlier. I'm just bringing it in so that you can be able to recap. Look at the last two bullets on the left-hand side. This emphasizes what Dr. Susan A had just talked about, especially nutritional and what Dr. Kiara talked about, issues of nutrition, issues of excessive weight loss, so those who lose weight, bulimia, or those who have anorexia nervosa, and then excessive exercising. This will affect you. The others are now the organic causes. Next. Okay. These are just to show, I think I've already mentioned about this. Continue. Next one. Okay. This is just a now pictorial representation of some of the factors. The fibroids, common cause of abnormality in menses. Remember, you can get fibroids even in the adolescent. The gynaes in the room will know that it's not uncommon to find an 18-year-old with even a 20-week size uterine size. Use of contraception methods, the hormonal, the various types of devices, the IUS, the pill, especially the emergency contraceptive pill. This is one of the commonest causes of abnormal menstruation in our ladies, so we should be careful about it. Next. This one is to add the other thing, abnormality in the uterus. You get urethral prolapse, and if there are polyps, this can give us problems. So we need to be careful about that. Then the issue of malignancy. And then Dr. Kihara talked about pregnancy. In early pregnancy, you can be able to see a bleed. And some people think that they have early pregnancy bleed and they think that it is prolonged miscarriage over a given period of time, but they are having early menstrual bleed. So better get a clinician to look at you, and of course, infection. Next, I think we're almost nearly done. Continue this showing pelvic inflammatory disease. Next. Now, PCOD, polycystic ovarian, this is what you'll see in an ultrasound. This is one of the commonest causes of abnormal menstruation in the younger group. Either prolonged, or the interval can be for even up to 6 months. And when the menses come, it can take even about 3 months. Needs clinician intervention so that you can be able to correct the problem. Next. Endometriosis, this is a subject for another day. These are also one of the common causes, and endometriosis in the younger group. Initially, it was thought that it is not there, but those persistent menstrual pains, watch out for it. So when the young lady is complaining of pain which is persistent, don't just assume that it is so. No. We know 14% of them miss schools because of painful menses. So watch out for some of these common causes. Next. This is now in the APO axis. I'll skip this because this is a more pictorial illustration of the hormonal involvement. I'll show you an earlier slide. Next. In the next one, you can skip this. This just trying to explain the others. Okay. Remember variation in menses. The teenagers' menses can be very varied. The 20, 35, 36 year age group, usually it finds that it stabilizes. Then after 36, going towards menopause, the menstrual pattern starts changing again. And of course, postmenopausal, when you have bleeding, then there's trouble. You have to rule out malignancy. Next. Okay. I've talked about postmenopausal. You need to be investigated further. Let's go on. Okay, this is the common thing we see. Women, the younger group, with all manner of postures. I'm sure the ladies in this room know what these pictures represent. Okay, it's unfortunate I'm talking after already the ladies have spoken. I may not have an obvious experience, but at least you have seen ladies with this kind of pictorial postures. Next. Okay, this was just to show you the colors you get. When you get this cranberry color is normal, blueberry is abnormal, strawberry tells you, you can look at the menstrual pattern and it will tell you whether you have a problem or not. So watch out for the colors. It's always good to document it when you're going to see your doctor. Next. Okay, these are the things every woman dreads. You are bled until your dress is is all stained. You stand up and everything is falling onto the floor. Your undergarment is all bashed up. This is a representation of heavy bleeding, and this must always be looked at. Only about 14% of them require, no, only for about 14% of them are usually would consider that you may not pick up an obvious cause. Most of them, there's a reason. Next. Okay, I've mentioned about this. Let's skip it, continue. Okay, some of the other causes, stressful life. Because when you have got those kind of heavy menstrual flow, this is what all the ladies go through. You have to have a bag with all this. You have got different sizes of the OBs, the mini, regular, sometimes you have the super, you have all the bigger parts, panty lining. So your bag is just a full of all the things which you're using for your menstrual hygiene, whereas you should have been carrying your other things. So it makes you become very stressful. Next, almost done. Okay, let's keep this. I've talked about PCOD. Continue. Yes, some of the other things, misuse of medication. These are also some of the things that bring abnormal menstruation. You see Postino, you take it, and throughout, some people take Postino every time they have a coitus, even if it is 10 times a month. This brings all the abnormality in the menstrual cycle. So this brings problems. So we watch out so that we avoid this. Okay, next. So the necessary advice. Give ladies the necessary advice to be able to take care of their menstrual care. so that they can even be able to quantify so that you know whether it is a lot or less. So the advice is crucial. You can see this lady is really engrossed. These are the team who are doing this work in Korogosho, and they have made a lot of difference in the young ladies in that community. Next. So when ladies understand themselves, this is the kind of picture we need to have. People taking their selfies and very confident, and they are not going to be worried of anything. Next, you're almost done. So this is what, if they're in pain or there's a problem, give them the correct medication. Avoid telling them use this kind of weeds or go and do all manner of things to be able to stop you from getting heavy and painful menses, and this will revert your menses to their normality. And then giving a panacea of medication which you don't know which ones is which. Some of them given in some of the back streets of Nairobi, single tablets, some from Chinese, from wherever, and you get all manner of outcomes from them. So we do what is correct, not what is correct, and that's what we want them to do. Next. So we should have, as Monica had mentioned earlier on, what they are doing through Keynote. We have proper sanitary towels, so the young ladies are advised properly so that they use what is comfortable to them and will make them be comfortable and be able to quantify if there's abnormality. They can tell you, I've used so many pads, I've used so many of the OBs. Then you as a clinician can be able to advise appropriately after quantifying what you think they have used and therefore advise whether there's abnormality or not. Next one. If there's need, they go and seek healthcare, appropriate healthcare, not what will be of no help to them. Next. So when they start being comfortable, they can be confident, sit and look at the horizon and feel happy. Next. Then when they are happy, they celebrate, they can put on whatever, and if they take care of themselves and they understand what is going through them, they can put on all manner of undergarments and they'll be confident and they will not be worried. They can celebrate whenever they want. Next. So at the end of it all, some people will have menstrual cycle which differ with your cycle. That does not mean that your cycle is abnormal. Yours is unique to you. But if prolonged, as I have mentioned earlier on, of course, there's a problem. If very painful and varying with the previous patterns, there's a problem. If there's no pain and varying with the previous pattern, there's a problem. If there's false smell, there's a problem. So these are the things which, when a lady wants to know what's wrong with me, these are the simple things you need to just put at the back of your hand so that you can be able to tick them 1, 2, 3, 4. Next. So we would like to see ladies who are confident and happy, not somebody who is groaning like the lady on my right-hand side. Thank you for your attention.
Thank you so much, Professor Oo. I'm actually very impressed. You're very knowledgeable with what we walk through. So we will now move to Esperanza Kippanga. In our department, we strongly believe in mentoring the younger generation, and this is no exception. So she is in the University of Nairobi, currently a fifth-year medical student, rotating in our department. So I did give them a challenge as a group of class students and said, can you come and tell us the reality on the ground regarding the software and the hardware? So let's have a listen into what Esperanza has for us this afternoon. Welcome.
Thank you very much, Dr. Kihara. Thank you everyone for your audience and for this opportunity to speak to you. As you can see, these are my classmates that enabled this presentation to come to life. What I am going to do is just to speak on their behalf. So next slide, please. This will be the scope of my discussion today: the hardware challenges, the software challenges, and the medical sequelae of poor menstrual health. These are things we have heard already this afternoon from other speakers, but I'm just going to put them together in one basket, so to speak. Next slide, please. So first of all, the definition of menstrual health management is when women and adolescent girls use clean menstrual management material to absorb or collect blood that can be changed in privacy as often as necessary for the duration of the menstruation period, using soap and water for the washing of the body as required, and having access to facilities to dispose of used menstrual management materials. And it is upon this definition that we tried to explore what problems there are amongst our peers at the university, and even amongst adolescent girls and the younger girls in primary school. Next slide, please. So what are the challenges that ladies face out here? So the first set of challenges is based on the menstrual hardware. So we have four main issues. Yes, next slide, next slide. We have four main issues that are depicted here. So this is the ideal that would enable a girl who transitions into adolescence to be able to continue with school, be able to get pregnant and successfully transition into menopause. So at the extreme left, you have top left, you have food provision, adequate food, and in particular iron. Iron as a micronutrient for ladies, because not only is there a very high demand for this in adolescents as they're growing, but even in general, because of the loss, the demand is much higher. So as Dr. Susan had mentioned earlier, a well-balanced diet that meets all the needs of a lady as she's growing and as she's going through the reproductive years with the menstruation, this is something that is very important and key in maintaining their health and dignity. Just below that on the left, there's the little girl with the soap bubbles on her hand, and that represents the need for water and soap and hygiene facilities, because as we know, blood is a very good culture for bacteria. So considering that menstruation is a very intimate process, it's a process that needs one to take care of themselves adequately, these are facilities that must be provided for any girl to go through menstruation in a decent manner, in a dignified manner. To move to the right, we can see now the products that are required now for actually handling the blood. We have the sanitary towels depicted there. We have the sanitary towels, tampons, menstrual cups. All those are the ideal hardware that we would like each and every girl to access. And then below that, we have the disposal methods, again, that we would like each and every girl to be able to access in public spaces and even in private spaces. Next slide, please. So despite what the ideal looks like and what we would like each and every girl to be able to access, this is the reality on the ground. Again, on your the top left, you can see we have the problems of malnutrition. We have both under and overnutrition. Not only does this put any lady at risk of iron deficiency anemia, but many other attendant risks that come with the complications of poor menstrual health, menstrual hygiene management. Then you look to your right, we have the sanitary towels, the tampons, the cups, and these are, to some of the ladies in this country, in fact, majority of the ladies in this country, those who live in families that survive on under $1 a day, this is actually a luxurious commodity, because in as much as when you go to a shop and you look at the prices of pads, you'd think 80 shillings, 100 shillings, 150 shillings for a pack is very affordable for you or me. It's very difficult for a girl who's in a family of 8 children, whose parents are casual laborers, to access this commodity, because in a day, that's 100 shillings that would buy one pack of 8 pads that are not even sufficient for a single menstrual cycle. If she has heavy flow, for example, that 100 shillings is meant to feed the whole family. So it becomes a gamble between, do we sustain dignified menstrual health or do we survive, basically, for the whole family? In your bottom left, you can see dry taps right there, which reminds me of when I was much younger in primary school. We used to live in Machakos, and my parents were civil servants, and we lived in a government house, a government-provided house. But funny enough, or ironically, we had water problems in that house. So sometimes we would harvest rainwater. And I ask myself, if in my relatively privileged position, I still had difficulties accessing consistent supply of water, what about the girls who are born to families that live in informal settings? What happens to them? How do they access their water? They cannot even access decent sewerage systems. So that's another problem that greatly affects young ladies. And the last problem on the extreme right bottom, you can see there is disposal of waste management products. Yes, you may have access to the sanitary towels, you may have access to one form or another of menstrual management products, but how to dispose of them is also something that needs to be provided, something that girls and women need to be made aware of, because we have seen previously in boarding schools, sometimes you find that toilets get blocked because young ladies will use the pads, the sanitary towels, but instead of using the actual provided bins, they will flush them down the toilet. And this is just a clear depiction of the lack of knowledge of how to handle the menstrual management waste. So that's another problem. But that's even for the ladies who are in the more privileged settings. Because if, again, we go back to the young lady who is in a family of 8, living in a barely surviving in their family, who cannot even access the menstrual hygiene products, they cannot imagine where to get, they cannot imagine that such services for disposal exist, because they don't even imagine that the menstrual management products exist. So these are the hardware challenges that people face. Concerning the sanitary towels and tampons, recently one of my classmates, in fact, one of the ladies that helped compile the slides, made an observation that in our institutions of higher learning, when you go to the public washrooms, there are no dispensers for sanitary towels, there are no dispensers for tampons, or basically anything that supports menstrual management. And in as much as there is a government initiative that supports distribution of sanitary towels to primary schools and to secondary schools, public primary and secondary schools, most of the students doing their undergraduate studies are as much dependent as students in primary and secondary schools, pardon me. They're as much dependent as the students in primary and secondary schools. So it would be pleasant if there was a way that this need can also be met among the older youth in the public universities as well. Next slide, please. So periods don't stop for anyone. That's the fortunate or unfortunate reality for the ladies amongst us, that every month they will knock on your door and you will have to find a way to deal with them. And so following this, we also have software challenges that face ladies. Next slide. These are the 4 challenges that I'm going to talk about: period poverty, affordability, accessibility, and acceptability of the methods. Next slide. So period poverty is defined as the inability of young menstruators to afford adequate menstrual hygiene products, as well as the associated stigma around menstruation. As I had mentioned earlier, sometimes the sanitary, the commercial sanitary management, sanitary towels and tampons that are available are a preserve of a few. So there are articles, if you read from young girls, and even maybe if we inquire from Keynote and Dr. Monica, we would find that there are young ladies who will tell you that because they cannot access that, they have to find alternatives. They have to, as we have seen earlier, have sex in return for money to access these things that they cannot avoid, because, as I said earlier, periods do not stop for anyone. You find the scenario where they will make shifts to be able to handle menstruation. They will use something as extreme as sawdust, feathers, things that, if you think about, really reduce the dignity of a young girl as she's growing up, and comes with so many other attendant problems that we cannot pretend do not exist, and we must try to solve as a society in general. Next slide, please. So as I said, we do have period poverty. That's just an illustration of, you may have the knowledge that these things exist. Young ladies may know that periods, pads are there, tampons are there, but then again, there's a barrier in terms of the finances. Next slide, please. So apart from just the finances that enable young ladies to access this provided material, there's also the problem of secrecy and stigma and the societal attitude towards periods. Because when girls are in primary school and in secondary school and going through adolescence, there's that aspect of just starting to discover what adulthood is about, starting to discover what your body is going through, starting to understand what your body is going through. And at the same time, they're not living in a world of isolation. There are boys, you know, as Dr. Monica had said, there's the aspect of being teased, there's the aspect of, you know, being taunted by their counterparts, the male counterparts in the schools. So this is one of the things that I actually really appreciate, what she has said about integrating the boys into the sexual and reproductive health sessions, because among the medical fraternity, we may be privileged to understand that this is a natural process, but you would not imagine what goes on in the mind of a young man who has probably only gone to school until class 8, when they encounter a lady who has soiled their clothing. For them, it's absurd because they do not understand it. So I think that's a very good initiative and a very effective way to ensure that we are bringing up young men who will not only understand what is going on, but will also be able to provide information to their sisters, their cousins, their ladies, and, you know, just support the whole natural process and make it more dignified than it is. Next slide, please. So the aspect of affordability, again, still stems from the financial challenges that ladies have. And there's also the concept of tampon tax and period tax, sorry, not pink tax, period tax. On the bright side, in Kenya, we did have the repeal of the taxation on menstrual health products, which I think was a very positive change, because it affects ladies in an imbalanced way, because men do not menstruate, obviously. So that is something that will put ladies at a more disadvantaged position financially. And if you think about the fact that it's not a choice, if I am able to buy sanitary towels, I will not think about it. I'm not going to calculate and say, okay, maybe this is a cost I can cut down from my monthly expenses. It's something I must be able to cater for myself if I do have the financial means. So I think that was a step in a positive direction. And even the initiation of supply of menstrual products in schools, that's also a step in the positive direction. But then again, the effectiveness of the implementation is something that still needs to be improved, because it has not been extended to all women and all girls in marginalized communities. So that is something that still needs to be addressed. Next slide, please. In terms of accessibility in terms of, yes, having the finances, but also having the knowledge, because we know that not every girl knows what they can access in terms of menstruation management products. According to the Indian Health Ministry, and India is quite comparative to Kenya, considering our financial status as countries is comparable, only 12% of menstruators have access to menstrual products. So everyone else is left to find their own way to navigate something they cannot avoid. So according to the same article by UNICEF, most girls may not know where they may find menstruation products. And so that brings up the problem of accessibility. It is a factor of many, many, many things in society. Not only are we missing the link between those who have knowledge and those who don't have knowledge, but we're also missing the link between those who are able to provide the services and those who need the services. So continuous conversation, continuous creation of awareness, continuous teaching of the young girls, continuous reaching out to primary schools, secondary schools, and even institutions of higher learning is still needed. And I think this is one of the ways that we are increasing the accessibility to this knowledge and the accessibility to the material that is needed by young ladies. Next. So in terms of acceptability, if you ask any random young lady, in fact, among secondary school students and primary school students, most of them are only familiar with sanitary towels. They're not familiar with tampons, and they're not familiar with menstrual cups. And even those who are familiar with menstrual cups and tampons are not well aware of the uses and how to dispose, how to clean for the menstrual cups. So that doesn't allow girls to find an option that sits well with them, because pads are not efficient for everyone. They don't sit well with everyone. There are those who have reactions, skin reactions to the use of pads. There are those who have extremely heavy flows. They would need tampons. There are those who cannot afford to continuously purchase pads, so they would probably make better use of a menstrual cup. So the knowledge of all these options also needs to be discussed, in as much as we are still in the stage of at least trying to get the conversation going. We also need to broaden the options for the ladies experiencing menstruation. Next slide, please. So as an effect of poor menstrual health management, menstrual hygiene management, we have the medical sequelae of this. And that is what I will talk about. Very brief, one slide left, next slide. These are the main ones that are there. It goes without saying that reproductive tract infections would be a problem that follows poor menstrual hygiene, because of course, as I said, blood is a very good culture medium for microorganisms. At the same time, you're exposed in terms of having to clean yourself, in terms of if it's tampons, using a foreign material, foreign body within your reproductive tract. So it goes without saying that this would be increased if hygienic conditions are not provided for ladies. The second one is toxic shock syndrome, which is a medical problem due to infection with Staphylococcus, which is a commensal of the skin. And because you're handling yourself, your skin has Staphylococcus, you're using tampons, for example, unless you have access to water and soap and a constant supply of tampons and options to know which tampon is good for you, how long can you use a tampon or how long can you not use a tampon, unless you have exposure to all that information, then there's a risk that this could come out as a result of even already having access to the menstrual management products. So knowledge cannot just end at this is what is there. It needs to go beyond that into sanitation options, into how to use the products that are there. The third one is urinary tract infections. Already we know that ladies are more predisposed to urinary tract infections in comparison to our male counterparts. And on top of that, we are now introducing blood in the genitals. We are introducing a lot of changing of the foreign materials. We are introducing the need to clean up, all that is going on in the genital area. So because of that, there has been studies that have shown that there is an increase in UTIs when there's poor menstrual hygiene. And last but not least, we have psychological distress that accompanies menstruation, because a lady is going through pain sometimes. Sometimes you're having heavy flow that is making you constantly conscious of whether you're soiling yourself. You're constantly thinking about when you can access a toilet or when you can access a disposal facility. You're constantly thinking about within the next 4 hours, will I be able to, within the next 4 hours, and that's the maximum actually, will I be able to change? Will I be able to do all those things? It becomes even worse when you're in an unfamiliar space. Maybe you're in school or you have a meeting somewhere. And on top of that, you now have to deal with the social stigma that is there. And for the younger girls now, they have to deal with not having access to what they need, the basic things, the material, not having access to the water. And then if perchance they have an infection and they see an abnormal discharge, or they get itching, or they have malodor that comes with poor management of the menstruation, then again, it just goes to bring down the productivity in terms of education, in terms of career performance. Yes, so that is one of the things that we'd also like to cut down. Yeah, that was the last point concerning medical sequelae, and that's my last slide, if I'm not mistaken. Next slide. Next slide, yes. So those are the references. So in general, what we would like is for every woman to be dignified and to be able to experience their femininity in comfort. I don't know if you have seen on social media, ladies posting that I wish my menses would just send me a text and tell me, okay, you're not pregnant, we're good, you're still fine, nothing is wrong, see you next month. Because it is an arduous process to go through. And it would be so much better if it was at least dignified for every woman. Thank you very much.
Thank you very much, Esperanza. Well done. Now, last speaker, but not the least, and this is where we hit the road looking at the practicum. What are women saying they really want? What are the young girls saying they really want? And we have no other than Sandra Marania, who is part of the White Ribbon Alliance group and is a policy advocate and a fearless campaigner for youth and women's health and rights. She has been instrumental in developing progressive policies, strategies, and campaigns, including contributing to thought leadership on effective youth engagement and gender diversity mainstreaming, what we are now calling transformative gender approach. Sandra's combined 10-year experience in anthropology, global development, and strategic advocacy. Campaigning continues to influence her engagement with the communities, including young people, women, and marginalized communities. She is currently the Advocacy and Programs Manager at White Ribbon Alliance Kenya. So Sandra, please tell us, what are girls saying they want? What are women saying they want in relation to the menstrual day today?
Good evening, everyone. I hope you can hear me clearly.
Yes, we can.
Great. Thank you so much, Dr. Kihara, for the wonderful introduction and to the forum for having us here. I say us because I did not come into this forum alone. I come here with a movement of women, girls, professionals, health workers, and passionate advocates for reproductive, maternal, and adolescent health. And it is always a pleasure to have this cross-community conversations, with academia and health and the medical community, particularly on issues that affect women and girls' health. And as Dr. Kihara has said, we are here to speak about menstruation. What did women and girls in Kenya, what do women and girls in Kenya think, feel, want for their menstruation? Next slide, please. So let's have a conversation about menstruation. And I'd like us to begin. I know the previous speakers have really emphasized the context, the situation as it is in terms of the menstrual health landscape. But I want to really emphasize that point. Next slide, please. Which is in the 21st century, 2021, we still live in a world where cultures still vilify menstruation and consider period blood to be dirty, to be impure, and menstruation as a topic to be taboo. And some of these facts were already shared, but I'm just going to read them because it's mind-boggling that we're still hearing these things this century, this era. That we have 73% of women worldwide either sometimes or always hide their periods from other people, or embarrassed, 68% embarrassed to talk about their periods with men. It's a girl's issue, it's a woman's issue. We still have 1 out of 10 school-age African girls not attending school during menstruation, which, as has been already expressed, I think it's Dr. Kiara who mentioned, an average of 3 days out. And we saw this especially last year with the COVID pandemic, the impact of the COVID pandemic when the schools were closed. Where not only were they not having, because the schools also are a safety net where they access some of these menstrual products, but now that they are home, they're not only accessing the products, but then they're also at home and not accessing the education. And that also in this day and age, many women and girls use unsanitary materials such as old rags, dry leaves, grass, ash, sand, newspapers, or even socks, because they do not have access to affordable, hygienic, and safe products and facilities, just like Esperanza had just talked about. And even this one, which I thought was very funny when I found it, is that in Kenya, menstruating women are not allowed to touch or milk cows for fear that the cows will get sick or die. That is how deep the depth of the period stigma and the taboo that is there around menstruation. Next slide, please. So it is so deeply ingrained that we found that even the word period is not used. The word menstruation is not used. We've found that we have other terms that have been used to hide behind or to cover this very important issue. I am not well. When you hear someone, a girl saying I am not well, or a woman saying I am not well, that it is stake week, or it is that time, or we hear about anti-flow, or my monthly friend, or code red, Bloody Mary, on the rug, red wedding, kunyesha. All these are words that are used to actually hide behind the word period, because it is such a taboo topic that people are very embarrassed to talk about, not just the women and girls, but then also the communities around the women and girls. And this is why in this moment, as we have this conversation, we have to rally behind ending period stigma, because it is still real. Next slide, please. Now, I'd like to spend some time talking about, the meat of the conversation, which is what have women and girls said about the menstruation. As a movement, Reusable Alliance, like I said, we're a movement, and a lot of the work that we do, a lot of the advocacy that we do is centered around the women and girls experience, not just the experience, but also the self-expressed priorities, self-expressed thoughts and needs. And so 2 years ago, we conducted a campaign called the What Women Want campaign, and it was we were seeking to ask them to find out what is that one thing, what is that one request if they're asked would be the top request for quality reproductive and maternal health services. We were able to successfully ask over 1.1 million women and girls from across the world. In Kenya, we captured 20% of that. And from the results that we got many results revolving around respectful and dignified care, wash, access to medicines, but then also menstrual health. In Kenya alone, we were able to get 150 responses from Kenyan women aged 61 and under who talked about their menstruation in diverse ways. And that's what I want us to take a deeper dive into. But before we do that, I just want to tell you that we were able to curate all the responses that we got from the women and girls regarding what their top health demands were. And we've put them in a digital, we've been able to create them in a very interactive dashboard online. So if you go to whatwomenwant.whiteribbonalliance.org, you will find a dashboard that has all this data, women's voices in their own words. And so next slide.
Please mute that speaker. Thanks.
Thank you.
Go
next
ahead.
Slide, please. So now what I want us to look at is some of the responses. And these responses, as you see on your screen, these are not our words. We actually copy-pasted from the repository of responses that we have. What we have done, however, we've tried to group them, but these are overlapping. These are not concrete, solid groupings. I want you to read them even as you think of them overlapping and interrelational. But the one thing that I really want to bring to our attention is this, and I think the keynote address speaker, Monica Ogutu, spoke about it, which is in the menstrual health advocacy work or in the interventions, there's a lot of emphasis on menstrual products such as sanitary towels, provision, access, which is a very big issue. But what the responses from the What Women Want campaign told us a somewhat different story. That over 41%, or around 51% of the responses actually spoke to concerns around menstrual health intervention. So concerns about menstrual cramps, genital infections, or what I think I've learned from Professor Mondi Ogutu, which could be reproductive tract infections, and access to these interventions. So some of the responses read like this. They want medical services for cramps during the menstrual period. Women should be provided with specialists to deal with issues like menstrual cramps, proper medical care to ladies with improper menstrual conditions, effects of drugs when having menstrual cramps, treatment and prevention that acts immediately and is effective for menstrual cramps, and then cure for back pain and menstrual cramps. So this interrelational with menstrual cramps and other things, cure for blood pressure and menstrual cramps. Women with heavy periods bleeding should be offered tests. And then so this was a very specific one, cramps during menstrual period, and would like my friend to be helped, so she has a problem with ovaries due to cramps during her menstrual flow. And then sometimes gout bleed, but it's not menstrual period. So what is that? And then fungal infections and its interrelation with menstrual cramps. We had this is just a sample, but we had very many responses that spoke to that area. And the second one that was quite popular was around menstrual supplies, so links to accessibility and affordability of medication and menstrual products. And what I want to say from here is, yes, we have, so there's the medicines and the pads and all that, but I'd like to say that a lot of the responses were actually revolving around the first point in different variations, which is medicines, drugs, antibiotics, and painkillers to reduce menstrual cramps as one of their top requests. But they also talked about contraceptives and drugs for women with menstrual health problems that should be free, introduction of free sanitary pads to girls when they reach the menstrual age, avail pads to remote areas who use clothes, sanitary towels should be distributed in schools, free or more affordable menstrual pads, sanitary towels to be given for free, and then the concept of menstrual equality for all Kenyan women, including access to sanitary pads. The next slide, please. Then the other two categories that were there revolved around menstrual health and hygiene education, where we had roughly 28% of the responses. And this one concerned knowledge and awareness resources and platforms. So we had responses that spoke to menstrual hygiene education to be included in school curriculum for adolescents, educate the girls to know about the menstrual cycle, information on menstrual cramps, mood swings, and fever during menstruation, information on blood clots during menstrual flow, programs for health talks to women on how to handle menstrual periods, and foods to eat to stay healthy and strong. And that really came strongly in this session. Government to provide education to ladies to create awareness of things which particularly come in their lives, like menstrual cycle, pregnancy, and delivery. Providing training on hygiene and its importance to girls and women, especially during menstrual period. Causes of menstrual cramps, irregular menstrual flow. What are the best ways to stop this? I suggest vaccination. That was a very direct one. Longer periods for 1 week instead of 3 days. So this again about the irregular menstrual flows. And then self-control during menstrual period, which I really found interesting. And even as I was going through the comment section in today's forum, I saw a question around linkages to sex, sexual intercourse, and relieving the pain of menstrual cramps. So could that be connected? Because obviously, it's something, it's an issue that is revolving at the community level. And then the last category, which was somewhat cross-cutting, spoke to issues, broader sexual, reproductive, maternal, adolescent health issues, and economic issues. So responses like work on economic and alternative menstrual possibilities, more gynecologists in public hospitals, supplements for pregnant women should be free because of moving from one place to another due to climatic conditions. It has affected the menstrual cycle. So this came from the nomadic communities that we work with. Programs for cervical and breast cancer screening and should be free and more frequent. Protection from sexual harassment. And come up with a way that can reduce labor pains during delivery. So in a nutshell, those are how the responses were looking, right? And what that tells you, even for us as we were internalizing this, because we work with the premise that women and girls are the experts of their own health. And so even as advocates, as intermediaries, sometimes we want to look at health holistically. We do appreciate the biomedical approach, but even looking at it from a holistic approach, how do we then dissect this information so that it translates to effective interventions and programs and implementation that actually speaks to the needs of the women and the girls. Next slide, please. And so this is why I want to invite the audience, the participants of this forum, to let's think. Now that we know this is what the women and the girls told us, and truly should be the drivers of the seat of this conversation. When we call the parade and say it's time for action, what are we talking about? What are the reflections that we're getting from these self-expressed priorities? I can start us off by some of the reflections that we've gotten and that we're using to integrate into our programming, into our thinking, into our advocacy, but also invite you to think, because this is a conversation that is it's multifactorial, it is interdisciplinary, and it affects all aspects of life. Next slide. So one thing that should be standard is that all women and girls, no matter where they are, no matter who they are, should be able to manage the menstruation hygienically, safely, in privacy, and with dignity. And as we've seen from the responses, good menstrual hygiene management does require education. It does require toilets, water, soap, and other wash components. It does require access to menstrual products and other commodities, and also proper waste disposal. And then it also has this additional systemic factors that we cannot turn a blind eye to, which is informed professionals in whatever discipline or sector that you're in. But in this case, let's talk about the academia and the medical fraternity. Are you informed? Are you aware? Professor Mode Ogutu mentioned that most health workers did not even know today was International Menstrual Hygiene Day. So what does that tell us? But then also the positive social norms that, because already we've seen that the current social fabric is propagated by norms that propagate period stigma, taboos around this topic. And so what are the social norms currently in place? But then also policies, and this is something also Dr. Kiara had mentioned about, what is the current policy and legislative framework in place that is either enabling or disabling access to some of these factors? And then health services in both medical and non-medical settings. Next slide, please. And just to drive the point deeper, as far as why menstruation matters to everyone, just to show that it is so interlinked to so many other aspects of life that we cannot turn a blind eye, right? A key thing that has been mentioned is even in the beginning, when we started this forum, is that it matters to the boys and the men, right? And a lot of the taboos and negative social norms around menstruation are really perpetuated by society. And part of society, we have the men and the boys are most of the time excluded from this conversation. So how can they be brought in? How can they be enrolled so that they can begin to transform the negative social gender norms to actually then, bring up a positive conversation about, not just positive, but also informed conversation about menstruation, that it is no longer a taboo topic or a women's issue to talk about. But then also it matters worldwide. But women and girls around the world need to manage the menstruation. It's a fact of life, like we've mentioned, it's normal, right? Especially at the reproductive age. But yet we know women and girls they're diverse, they're socially located in diverse ways, So how do the social norms, the customs, the educational level, the geography, the socioeconomic status affect how they experience menstruation, and how are the people around those systems, what role are they playing to ensure that they experience this menstruation with normalcy and with dignity? And then there's also that menstruation is a matter of equality, and this is a very big conversation because it links to the broader sexual reproductive health conversation, but it also links even much broader to the gender equality conversation. If we're talking about accelerating gender equality, where women and girls, boys and men, and all other genders experience the world equally, experience resources equally, and have access to opportunities equally, then we cannot leave menstruation, right? Already we know, because women and girls are the ones who menstruate, there are certain realities that they're locked out of. So education, like we said, work, when you have painful cramps, and other opportunities in life, so that they can manage their menstruation. So how is the world coming around to ensure that, even as we're talking about gender equality, how are we cognizant of the menstruation reality that the women and the girls are going through? And lastly, it is an issue of inclusion. Again, just belaboring the issue of diversity, because we do have women and girls in different contexts, right? We have homeless girls, we have women and girls living with disabilities, we have migrant women and girls, we have women and girls living in extreme poverty. What specific requirements are needed to enable them to actually menstruate with normalcy and with dignity? Next slide, please. And so this is our call. Now that we've heard what the women and girls have said, and we've also seen that menstruation is interdisciplinary, multi-sectoral, it occurs everywhere and is relevant everywhere. What is your role in whatever space that you sit or act or have influence of? What is your role? The rallying call for this year's International Menstrual Hygiene Day is that we need to step up action and invest now. Invest so we ensure that girls have access to cards, that the tax exemptions are actually in place, not on paper, but in reality. Act to ensure that we have the different communities having this conversation, not just the women and girls, not just women's movement, and those who are, or people in the education sector. This has to be a conversation by everyone, for everyone, right? And step up, use your space. And I am happy, and I'm really happy, not just me, the movement, we're happy that the academia and the clinical fraternity is holding this conversation, not just as a scientific conversation, but as a community issue, as a social issue. So I call upon you, we call upon you to step up, action, and invest. We cannot afford to wait for the pandemic to end. We need more action in menstrual health and hygiene now. Next slide, please. I'd like to thank everyone for allowing us to have this conversation, but it's not done. Even beyond this forum, it's continuing. And so I've put some hashtags there. If you're digital, if you're active digital citizen, you can follow those hashtags to just hear and see and understand what people are saying around menstruation. And then plug in. Use your spaces to plug in. In case you have any other questions or you want to engage more, I've also put my contacts there and also our website where you can find much more information. Thank you so much. Over.
Thank you so much, Sandra. I think all of us have left here with 3 letters, DEI, dignified, empowered, and inclusive. And when I say inclusive, it's not just about equality, it's social inclusion, and it's including the men. Thank you so much. I'll hand over back to Dr. Kireki, probably to just take a few questions. I know we're getting closer to 5 o'clock, and then you can sum up and really tell us what is the role of the professional society and academia in relation to, beyond today, what needs to be done. Dr. Kireki, is he there?
Dr. Kireki seems to have dropped off.
Okay, fine. So I'll take a couple of the questions because they're fast and furiously coming in. And I'll start from the bottom and really speak to Professor Omondi Ogutu. I hope you're still with us, because a lot of the questions are actually directed at you in terms of the clinical areas. The myths around menstruation is wanting really, this is a comment from Andrew. I have asked, is it safe to have sex with menstruation? That's one of them. A patient who had heavy bleeding due to fibroids later developed anal genital warts. Is there any correlation? What are features of menstrual psychosis, not hysteria? And is there any medical treatment, or should we just perform TAH? Wow, that's a big one. Can steroids be taken for amenorrhea for 3 months? The last one, I think I'll just pick a few. What are some of the indicators of a foul-smelling flow? So probably, Prof, you can address that for us.
Thank you, ABC. Good questions. I know I was just flipping through the charts and I could see the questions were coming fast and furious. Now, foul-smelling discharge. It is interesting. This can be very traumatic and it can be as confusing as anything. Most ladies will come to you presenting and telling you that I have a foul-smelling discharge. You examine and you find that what is there is actually not a foul smell. Sometimes it can reach a point whereby you have a feeling it's a small foul-smelling discharge, but in actuality it is not. So it could be more of a psychological factor, but those are few. The truth of the matter is, if you have a foul-smelling discharge, most of it you find is purulent in nature. That would entail that, of course, when you have an odor which is a malodorous in nature, something which is not what you are used to before, you better be seen. And I have to bring this, and I'm sure all of you know, one of the commonest features you get is that injudicious use of sanitary towels. And here I have a strong word to put across that there are some people who do not remember to remove their OBs. And don't be surprised a patient presents to you with this kind of a feature. I'll just give you an interesting story. Some of the ladies or who is who in this country presented to me with a foul-smelling discharge. You examine, you do a speculum, you see some dark material in the vaginal canal, you say, oh my God, I must be dealing with a fungating tumor. You check and you find it has got more tissue-like, and when you pull it out, you find it is an OB. And you can imagine the kind of embarrassment that entailed. The story of what happened to the couple after that is for another day. It was very interesting. I wouldn't want to mention what it was about. So go and advise to be seen. Now, why would we use a steroids in a patient with amenorrhea? Patient with amenorrhea tells you one thing. Please, there's trouble. Look for the cause and then treat it appropriately. So you need to categorize. Is it a primary amenorrhea, meaning that this lady has not gotten a menses, or is it a secondary amenorrhea? Investigate. Don't just give steroids for the sake of it. It may not be necessary. So let's avoid giving medication where it is not indicated. Now, menstrual psychosis. Yes, in the younger ladies, and sometimes even especially those in their early 20s, it's not uncommon to find that there are those who have got typical features of psychosis, may not be that significant, but they start having mood swings, vomiting, like I mentioned, headaches, and generally find that they become very unstable. And this is something which needs, one, a psychiatric assessment. This could be a trigger to some of the other underlying issues. If it is somebody who may not have other underlying issues, then basically trying to reduce the levels of the hormones at this particular period as a significant one. So you may try to give them things which will control the amount of the estrogen-progestogen ratio, and use of contraceptives here works very well. So this is a real feature which can happen, and it does happen, although it's not very common. Now, the correlation between fibroids and anal warts, no, this is more of an incidental finding, because the way the fibroids arises and how the anal warts comes about are totally different. Usually, by the time you diagnose a woman with a fibroid, it means those things have been sitting there for quite some time. And as we all know, fibroid is a feature of the black skin because of the melanocyte stimulating hormone. There's a correlation how it enhances the conglomeration of the myometrium, coming and fusing together, and then they start growing out of proportion with what you'd expect to happen, then you get fibroids, which now start getting a roller coaster on their own. Now, interesting, sex and menstruation. Those of you who are very good at treating some of the old history will know that you are always advised that you should avoid sex during menstruation. But we know that the human nature has changed coitus to be for recreation and not for procreation per se. So telling somebody not to have coitus during menstruation is usually a very difficult thing. But we know that the good book in Leviticus, I think verse 11, one of my favorites, the book of Torah tells you, if a man has sex with a woman who is having her menses, you should be unclean until evening, and in some cases you may be unclean until 1 week is over. The essence of this is that during menstruation you are more likely to get infection. Why? Because the menstrual effluent is composed of cellular tissues, as I had mentioned, and also bacteria. So you are more likely to get infection during this time. So we should be able to avoid it if we can be able to, if we can. The first question was what was Dr. Kiara, was it on information on what? Or was it on inflammation? I didn't catch the first question. What question did you ask? Was it on? I didn't get the first question clearly, maybe how I wrote it down.
How does inflammation relate to menses?
Oh, okay. Remember, the endometrial tissue is a very interesting organ. And at any given time from the onset of with the menstrual cycle, by the second day when the repair of the endometrium starts at the level of the basement membrane, basal layer, as it goes up until you get to the follicular, then the luteal phase, there's always inflammatory process taking place. And there are lots of phagocytic cells within. So if you have got inflammation and you have infection, whereby you now have endometritis, meaning that you have got infection in the endometrial lining, the menstrual flow you will get will be heavier, because with inflammation, there's increased blood flow to the endometrial lining. And at the same time during menstruation, the normal mechanism of spasms of the spiral arteries, which control the loss of blood during the endometrium, is lost to some extent. They are not as efficient as they are supposed to be. And therefore, you tend to lose more when you have an infection than when you have got a normal menstrual cycle. And that's why inflammation is significant. Inflammation, if I have to go further, which I would want to, inflammation also has got a role in making sure, in ensuring that there's some degree of inflammation which enhances implantation of the ova when you are pregnant. But if the inflammation is extreme, it will lead to that pregnancy loss. So it goes either way. We need to have an optimum level. When it is beyond a certain level, then the uterine natural killer cells increase in number, and then you lose that pregnancy. And sometimes you tend to even bleed heavier, especially if there was an earlier pregnancy which is to be implanted. Thank you.
Thank you very much, Professor. I put you on the spot because majority of the questions were for you. There are some that I have addressed actually directly.
Thank you.
But I must appreciate each one of you. Monica, you gave a sterling keynote address. Sandra, you have given us very good insights as to what women really want. My medical student is to actually make everybody realize, even in tertiary facilities, you need help. My nutritionist, You have definitely given us better insights, and I really hope all of us can adapt and adopt to the rainbow diet and not the way we used to think about the healthy plate. And more so is observe what our adolescents and youth are consuming in the continuum of care, because it starts really from that point until geriatrics, where some of us are closer to. But my question for all of us as presenters in this forum is the so what? We have talked the medical, biomedical issues, we've talked about the advocacy issues. Maybe just get a snippet from each one of you, starting with Monica. What do you see as the way forward? How can you scale up even this innovative KMET such that everybody knows about it? I'm sure majority of the people in the audience are hearing about you for the first time and what you're doing. So each of us can actually give a snippet of what do you see as the way forward. I'll start with Monica. Dr. Monica, are you still there? Is she there? IT, is she there? Okay, so we can move down.
Monica is not there.
Okay, Joanne?
No, Doc, I'm here.
Good. Go ahead, Dr. Monica.
I was muted. I think to me, this was a great opportunity to bring some innovative strategies from the county. Actually, this is the first time we have been invited to such webinars, and I would really encourage that we invite more people from the counties, more partners, because there's a lot happening at the county level that you might not know, especially during this time of COVID. We have become innovative because we cannot wait for people from the West to come and support us. But what I would really recommend is that we need to have integrated models that will leave no one behind. Meaning, if it is comprehensive sexuality education, we have age-appropriate packages. We bring everybody, girls and boys, on board. We go community. We also engage the teachers. We have realized the teachers are also as ignorant. When we are having the sessions, they are really keen to learn. So it needs to bring health and education and other like-minded partners together. So let's have a multi-sectoral team and integrated models. That's the only way we will be able to destigmatize some of these sensitive issues like menstruation. Thank you, and back to you, Anne.
Thank you, Monica. Jane, Koetch, please tell us from the community perspective, where do you see us moving forward? Jane?
Jane is not with us as well.
Okay. Adongo Susan, are you still with us?
Yes, I am.
Okay, where do you see us moving forward?
Well, my final words would be if we are able to manage nutrition early for the adolescent girl, then we will not be playing catch up. We will be ahead of the game so that if they get complications later to do with in pregnancy or fibroids or chronic illnesses, then we will be able, then we won't be playing catch up. We'll be able to manage the situations earlier.
Okay. Esperanza, what do you have to say?
I think what Dr. Susanna said is actually important. To address issues before they get complicated is really important. In terms of provision of services, I think we could do better in providing hygiene services for all girls, not just girls in higher institutions of learning. And I think we could do better also in terms of informing girls what they can do to take care of themselves during their menses. And I think KMET has started a very good, has given us a good blueprint that can be adapted across the country. Yeah.
Sandra?
Thank you. My next step but I would enroll everyone is to get into the self-care train. I think now we're in the era of self-care, and I think menstruation is core to that. Recognizing that the women and girls, the menstruating women and girls are experts of their own health, and they need to know that. They need to know that they have that inherent power, and make use of the resources, if it's education, if it's the services, but then also bringing in other actors like the health workers, medical fraternity, et al., to reimagine another relationship with them, because as we speak, the relationship with health, the health system is very top down, where it is because the doctor told me this, or because this expert told me this. If we can reverse that kind of conversation and we start reversing it by even breaking down, like I found today's session very insightful, very informative. I only wish that I got a lot of it in layman terms, so that I can transport it back to the women and girls. But even for technocrats, I struggle with some of the terminologies. So how can we repackage that information so that we can use it to empower the girls to use it as experts, to speak out for themselves, and bring the other actors, the systems, support systems around them, to transform how they experience the world, how they experience menstruation, talk about menstruation, and ultimately transform the equality that we're talking about, the gender equality and the landscape as is. So that is it, and just also recognizing again as an emphasis that menstruation matters to everyone everywhere. And so it's a call for everyone wherever they are to come in and take their position, remembering that the women and the girls are the ones who are on the driver's seat. Thank you.
Thank you. Professor Omondi Ogutu, a snippet comment.
Yes, thank you. This is a very, very important discussion we had today. I would put it this way. Going to bring in the media, then you have got the NTV, you have got Citizen, you have got KTN around you. Then you are calling in a group of 20, 30 girls, and you are giving sanitary towels, and you get all the accolades that I went and supplied maybe 20, 30 loads of sanitary towels. That really is not the thing. The thing is, we should go beyond that. Providing sanitary towels is just the end of the tail end of the issue. We should now move forward as those with the knowledge and teaching institution to start ensuring that those who are handling the young girls and even the teachers in those who should be able to talk about menstrual health, sexual health freely with these people, arm them with knowledge, let the parents also be told that this is what you need to know. All the parents know about this, but how many parents talk to their daughters about it? So the element of advocacy, of which Dr. Kihara is very good at, should be escalated, especially at the ministry level. I think they should even be like you have those sessions on talking about family planning, should be having sessions talking about menstrual health, especially to the adolescent, no holds barred. And that must be the key. Talk, talk, talk. The more we talk, the more information we'll get from them, and then we'll get questions being asked. What is it that I need to do? So the issue of a border giving the young girl the towels, it may not be there, because once she understands herself, then she will know this guy is just taking advantage of me. You talk to them about those taking advantage. Anybody at the most vulnerable will be taken advantage of. So stop that cycle, and we empower them by empowering ourselves and those who talk to them and the people they have confidence in, and will make a difference in the women's health. Just to add one last thing, remember, if today is the World's Menstruation Day, and hardly even the women do not know. So that's where we start from. Let us be empowered with information and knowledge. Thank you.
Thank you, Professor. We have Dan Okoro. Dr. Dan Okoro, are you still with us? Dr. Dan, are you there?
Yes, I'm there. Yes, Dr. Kihara.
would wish to give you an opportunity because you work with UNFPA, adolescent health is your pet peeve, and we are looking at demographic dividends. I think it's very clear that we will not achieve demographic dividends if we do not address menstruation for all. Maybe you can give us your insights, because the more I'm listening, the more I'm feeling there needs to be a coalition, yeah, that is formed out of this. A few words.
Yes, a few words. And first of all, let me appreciate the work that has gone in preparing for this. I've listened to part of it. I joined mid somewhere between, but there are great presentations from the, probably I may have missed Monica's presentation because by the time I joined, she had already presented. But okay. Generally, I think it's quite a great discussion, as I've mentioned at the platform there. That we are currently opening up and discussing menstruation or menstrual cycle, the menstrual hygiene or menstrual health in its various forms. And the time that we are growing up, I remember talking about the engagement of the boys. And for me, menstrual, the blood, the period as it was, we used to call it, was nothing that I was even imagining. At class 7, I think the girl that we were sitting with happened to have to drop a blood on the desk because we were sitting two boys, one girl, the girl in between. And I had the older boys, the time we were growing, some of them were much bigger in their late teens. And they started ridiculing this girl, and this girl never came back to, because at break time she went home and she never came back to school for the next 2-3 days. And I didn't know what is period. As it were in our direct translation of Ugutu knows, we call it the moon, that she's on a moon. So it's something which is disturbing actually for the girls to make them realize their potential. And as we say, UNFPA, one of the things that we look at is that realizing your potential. And if you miss, as many of the presentations here have alluded to, there are many issues to do with the poor menstrual health. So we need just to support, be strategic and innovative enough and pass that information. As Professor Gutu has mentioned, giving the PAD or addressing the period poverty comes to almost to the ends. But though it's very key, but the message, the information, the misinformation which comes with it is quite important. One of the counties that we are supporting, Iwawi in Migori, and Monica probably may be quite aware of this. It was quite saddening when you're addressing the issue of the first-time young mothers, and these are teens, that they would rather get pregnant to avoid the menstrual flow, the cost of the pads. So can you imagine that you're using pregnancy as a stopgap measure and not understanding really what comes with this pregnancy, what comes with the sexual, with the sex and that they engage in, and subsequently having the pregnancy, delivering, having the baby, and possibly sometimes they not go back even to school, they get another pregnancy again. So it is quite disturbing, and we good that this subject be discussed beyond our medical field, and I believe right now many people are getting engaged in it. So let's look forward beyond this and see how best to engage and really support on this. Thank you so much, ABC.
Thank you so much, Dr. Dan Okoro. I will pick you up on this. But my concluding remarks are these. My concluding remarks are these. We've just finished a 3-day National Leadership Forum on Population and Development. Menses and discussion around menstrual hygiene and menstrual health management is so integral when you really think deeper in terms of fertility, population and its demographic dynamics, motherhood, and demographic dividends, which basically speaks to the development agenda of this country. We need gender, equity, and equality in addressing this topic. Cultural systems, we need to have a rethink on cultural systems as regards this particular function. The other thing is environment and climate change. It has not really come out, but think of eco-friendly, degradable products as the way forward. Think of how nutrition then relates to even the kind of menstrual patterns we have and how it also relates with the climate change that's happening globally. Finally, two things, the research agenda around this. And lastly, social accountability. What are we doing as far as girls and women's needs and our responses to them? And secondly, what is the accountability by the state actors and public sector, non-public sector, us as advocates, and also having accountability even from the private sector? Ladies and gentlemen, I don't see any other way unless we begin to speak together, speak to one another, and not at each other. I think that will be my final parting shot. I want to recognize the work that the ICT has done, led ably by Dr. Kinuthia. All my presenters, accolades to you. All my participants, at which we got to a ceiling of 700 plus people. We're still at 400 and about 414, which means a lot of us have still stayed to the very end. And also to the moderators who have been quietly working in the wings. That is the rapporteurs. That is Dr. Kagema and Dr. Baraza. I know I haven't mentioned you previously, but it's important we recognize the rapporteuring you're doing. So with that, ladies and gentlemen, we've given you food for thought. I don't want you to just talk. Let's talk and act. And it's a responsibility, I believe, for all of us. All of us. If you're a gentleman, please be a partner with us and also take hold of your sister's hand. If you are a lady, you know and we know what we go through, but please have a sisterhood that can actually make a difference for the next person. We really appreciate each one of you having stayed on. Thank you very much. One question that's lurking, how do I get these slides? KNH repository, we normally will ask each presenter if they're agreeable, we will have the information in the KNH repository. This is a CPD awarded event. And also, it also has certification. So on this note, I think I will talk to Dr. Kinuthia. Are you there? If he's there, he can have the very last word. He's been silent in the wings.
Yes, thank you, Dr. Kihara. I think you have said everything. That's why I'm quiet. You didn't miss anything. But I confirm that once the presenters allow us to share the slides, we are going to post them in the website. And the videos are also available for if somebody wants to listen to any session or miss a session, you can be able to get that. And in addition, the CPD points are awarded. Just to say that we partner with Daktari Online to send the CPD points. They require about 2 weeks to be able to send because there are usually very many participants and we have many sessions. So please bear with us, but all the points will be awarded, and in case there is a delay, just get in touch with us and be able to figure out where the challenge could be. Otherwise, thanks to everyone for joining in and for the very good presentation and all the questions. They are really encouraging. Thank you so much.
Thank you so much, Dr. Kinuthia. Without further ado, I want to say au revoir, goodbye, but let's wait for the next symposium coming shortly. Okay, so have a good weekend, and please take note of the conference that's coming up in the month of October. We are open to receiving papers in that regard, and I hope we can all be partakers of the same. Thank you so much and have a blessed weekend. Bye.